Dr. Abhay Dalvi, faculty Dr. G. Siddhesh, Dr. Iswar Govindaraj, Dr. Sunil Popat, Dr. Satish Mitha, Dr. S.P. De Sarkar, Dr. Kanagavel, Dr. Subhash Khanna, and Dr. Satvir. ASI Secretary Dr. Sanjay Jain. Then ASI Jharkhand Chapter Secretary Dr. Sanjay Srivastava, our chapter patron Dr. R.P. Srivastava, and Chairman Surgical Vidyapeeth Dr. Sunil Kumar, and definitely all delegates and chairpersons. I welcome you all on behalf of both ASI and Surgical Vidyapeeth, and I would now request Dr. Sunil Kumar, who is the chairman of Surgical Vidyapeeth, to formally welcome all of you.
Good morning, everybody. It gives me extreme joy to welcome all of you, the national dignitaries and internationally recognized surgeons and endoscopists. It has been a long cherished dream to impart endoscopy to the realm of surgeon and make it horizontal. And it is in the effort in that particular direction under the auspices of ASI Jharkhand chapter. We have been doing it. 6 weeks ago, we did it for upper GI scopy. Now thought we should sensitize to the surgeons, especially surgeons of Jharkhand, and bring state and for that matter all over India for colonoscopy, therapeutic colonoscopy, and ERCP. And we have a dynamic chairperson, Dr. Arunima Verma, and her team in ASI Jharkhand chapter, under the persistent patronage of Dr. R.P. Srivastava, who has been at least giving his blessings and motivating all of us to do whatever we can do in COVID time. So again, a big welcome to all of you. Thank you very much for joining and giving your precious time on a Sunday morning. Back to Arunima, please.
Thank you very much, sir, for welcoming the gathering. And now I would request our chief guest, Dr. Abhay Dalvi, to give us a sign to formally inaugurate, because inaugurating it with lighting of the lamp is like spreading light of wisdom all across and knowledge all across. So Dalvi, sir, I request you to give us a sign for inaugurating.
Please go ahead.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampada.
With this, we formally inaugurate the conference. And now I would request our Secretary, ASI Secretary, Dr. Sanjay Jain, to say a few words, please.
Thank you, Dr. Arunima. Respected Dr. Abhay Dalvi, sir, President of ASI, Dr. Srivastava, sir, past President of ASI, Sunil, sir, and all the respected faculty and dear friends. It's my pleasant duty to convey the greetings on behalf of the ASI headquarters, and what I feel the Jharkhand has, as you
Secretary, ASI Secretary Dr. Sanjay Jain, say a few.
As we have seen this lighting of lamp. So what I will say that during this Corona pandemic, the very first program was conducted by Jharkhand people only, and you know, today there is a number of programs that every person who is academically inclined will have 2 to 3 commitments every day or the weekends. So my good wishes and big thank you for starting and making it such a good start that things are going really well. Thank you. Thank you very much.
Thank you so much, sir. Now I would request Dr. G. Siddhesh to say a few words, please. He is the ASI President-elect, and we would request him to say a few words to encourage us.
Thank you, Arunima, Chairman, Jharkhand Chapter, my friend Sunil, and our senior RP who is here, and my President and Secretary. So it has been really a joyous moment for me to be part of this event. Endoscopy is very dear to my heart, as you all know, and I am really delighted that a chapter has taken it as a 1 full day program to disseminate the and also to propagate and encourage young surgeons to take up endoscopy in their career. I hope that this meeting today will stimulate few more young surgeons who are not yet started thinking about it, and they will pursue this career in future, which will definitely help them as well as the public in general. So I wish them all the best, those who are attending delegates, and I wish the Jharkhand chapter all the best. Just as a reminder, please look out for the dates of the election. I'm being the election officer. ASA elections are going to be there. Enrollment is over for voting, but you can update your data. Those who are not yet updated, do log on to the website and re-register so that you will not default or you will not be left out for the defective thing and unupdated thing in the website. So please do it so that you will become a part of this election process. Wish you all the best again. Thank you very much.
Thank you very much, Dr. G. Siddesh. We are very honored to have you here with us. And now we also have the IAGS President, Dr. Sunil Popat, with us. And I would request him to say a few words.
Good morning, everybody. President ASI and Chief Trustee IAGS, Dr. Abhay Dalvi, President-elect ASI, Dr. Siddesh, past President and patron of this event, Dr. Sharma, ASI Jharkhand chapter, Dr. Sunil Kumar and Dr. Arunima, ASI Secretary, Dr. Sanjay Jain, dignitaries on the dais. First of all, my congratulations to ASI Jharkhand chapter organizing this wonderful second DME on endoscopy. Since last 5 years, I am seeing that all the surgical associations have become very active and aggressive regarding teaching and propagating endoscopy among the surgeons. This is a very welcome step from all the associations and from all the senior surgeons who are teaching and training the juniors. Jharkhand ASI chapter has always been very academic and vibrant and has given precedent to ASI also. And I am sure they are doing wonders, and in future, in this year and the years to come, they will do many more such academic programs. IAGS on its own is doing endoscopy FIAGS and advanced endoscopy FIAGS, which is known as FAGI, since last several years, and has been teaching and training online EFIAGS also. And we are very happy to see that this activity is being promoted and trained and skill training is done by ASI all over the country. My compliments to ASI and Jharkhand chapter, and all the best wishes for today's program and future such courses. Thank you.
Thank you very much, Dr. Sunil Popat. And now I would request our patron, Dr. R.P. Srivastava, to say a few words.
Dear friends all over the country, Vidoscopy in endoscopy. That's what I titled it. This activity, it is already titled somewhere. President Abhay, President-elect Siddesh, Secretary Sanjay, Sunil Popat from the West, the rest of the friends who have joined us from Jharkhand. The baton is in the hand of Sunil, Arunima, and Sanjay. When I dreamed this chapter in 2000 and worked for this, you know, it was a question of splitting. I'm not getting my video, so I'm welcoming you once again from the breakfast table, and my wife joins me in wishing you all, although you can't see her because she is not the right frame of presentation. So she is refraining, but she is welcoming you all. Having said this, when I was just sharing my dream, when I dreamed it out of Bihar, being carved out of Bihar, I was declared the bad man. But today with the activity, what dream I had dreamed at that time, I feel a lot of pride in this, that I was a part of formation of a chapter. I will not say that I formed it. I was just a part of the formation of the chapter. And this chapter has become so vibrant in spite of its geographically little left out situation in the country. But still the activities it has brought and which is being instigated, initiated and followed by Jamshedpur city branch and its patron like Dr. P.P. Chawla and doyens of that city branch, Sunil, Arunima and Sanjay there as well, is giving me more than the pleasure, which I will express. The endoscopy, I always saw it like a tool in the hands of the surgeon or the clinician, like the stethoscope. And now I'm very happy that it is being propagated aggressively by IAGS and ASI and Jharkhand chapter, that every clinician, every surgeon should have an access to look into the inside of the patient by his or her own wisdom, not being fed by an endoscopist and then work on that, because the surgeon faces the challenges for which he or she has to own every responsibility. So like a stethoscope was there in the yesteryears, the endoscopes are there here in the present era for every clinician. And hats off to Sunil. When you came back from England, I had listened to you about your dream. We were aggressively doing endoscopy in the city of Bokaro, but we are extinct now. We are left out. You have still pursued that dream. And I congratulate you and appreciate heavily that you pursued that dream to the fruitful example today. It might have taken years, doesn't matter. Your dream is going to be realized. The endoscopy centers in Jharkhand are going to be more than 1 or 2. I will still say that if it is available 150 kilometers away, it is still a good service. So let us see that a clump of districts, at least one center comes up for the basic endoscopy, and then it takes up to the higher center somewhere centered around the capital or any other city in Jharkhand. And then it goes on and on for other aggressive endoscopists in the country. Let's dream it like that. I will always be there. And I'm too happy, said least than felt. Again, I thank everybody on behalf of my wife, who has got the opportunity of at least listening to this deliberation and expression. If I would have been in the meeting only, she would have been left out. But at least thanks to this Corona time that we are talking to you from the dining table. Thank you, dear.
Thank you very much, RP sir, for your constant patronage to the society. And now I request Dr. De Sarkar, who is very active in endoscopy in the east part of the country, to say a few words.
Good morning, and really I'm thankful to Sunil, Arunima, Shadbir, as they are pursuing this thing, and in the great presence of our ASI President, Abhay Dalvi, also my friend, I think, and the Dr. Siddesh, Mr. President Sunil Popat, Secretary Ishar Murthy, even in this COVID era, this pandemic era, when we are losing thousands of our friends online, we went on with the FIAGS fellowship, continuing everything. So that's a great part. We are really passionate. People know for many years we are trying national level. In West Bengal, all the 22 medical colleges in the surgery department is given the endoscope. Still only 7 of the surgery department are doing routine endoscopies. Rest, I am trying a lot, asking everybody to send surgeons, junior surgeons to my center. Few have already sent. We are looking for going for all the 22 government medical colleges surgery department, doing routine endoscopy and giving exposure to all the MS surgeons in future. So with that hope and really great thank for this endeavor to all my seniors, juniors and colleagues, we will win someday. Thank you.
Thank you so much, Dr. De Sarkar. And Dr. Satish Midha is an icon as far as Jharkhand is concerned for carrying on with all the kinds of endoscopies. So I would request him to say a few words, sir. Dr. Midha. I think he was there. Sunil sir, I don't think Dr. Midha is there. Okay.
Hello.
Yeah.
Yeah, he's back.
Sorry, Anima, it got disconnected.
Yes, sir.
Thank you. Thank you very much.
Sir, please unmute yourself. Sir, you're muted. Yes, sir.
Good morning, everybody. Regards to the senior faculty members, Dr. Abhay Dalvi, Dr. R.P. Srivastav, Dr. Siddhesh, Dr. Sanjay Jain, Dr. Chawla, and other senior members, and many friends of mine. Endoscopy, like others, it has been my passion too. And we have also tried to develop this in our region. Many a times when we started minimal invasive surgery, we had to learn endoscopic procedures for compulsion because there were very few people who were doing therapeutic work in this part of the country. So luckily, I had the exposure of being with Dr. Nageshwar Reddy and Dr. G.V. Rao for some time, which helped me a lot in picking up the things and then proceeding further with the help of many senior gastroenterologists, including Dr. Krishna Rao, Dr. Amit Mahadev, Dr. Patnaik, Dr. Goenka, etc. And we have been pursuing in IAGS, as Dr. Popat has said, and Dr. De Sarkar is also one of who is the chief of the endoscopy board now, has a equal passion for all this. So I wish this endeavor a great success and hope that we will continue with the same spirit in coming days and maybe start with some hands-on training in coming days when things are normal. My all good wishes. Thank you very much. Namaskar.
Thank you so much, sir. And now I would finally request our chief guest, Dr. Abhay Dalvi, who needs no introduction. He's the president of the Association of Surgeons of India, and he's been leading from the front, and he has graced the occasion by sparing his valuable time early on a Sunday morning. So, sir, please address the gathering and say a few encouraging words to us.
Thank you, Arunima. Dr. R.P. Srivastav, past president of ASI, Dr. Siddhesh, president-elect or vice president of ASI, Dr. Sanjay Jain, honorary secretary, Dr. Sunil Kumar, the chairman of this conclave, Arunima, president chapter of Jharkhand, Sunil Popat, IAGS president, Dr. Chawla sir, a senior member, and respected faculty. A very good morning to you. It's a pleasure to see Jharkhand State Chapter conducting this program on ERCP and colonoscopy. Endoscopy has always been important for surgeons, and no less than Dr. B. Krishna Rao, the past president both of IGS and ASI, had propelled this endoscopy into surgeons' lives. Unfortunately, the gastroenterologists have taken over endoscopy, but now a fresh thrust from various state chapters as well as ASI has put endoscopy into the life of a surgeon. ASI, under the National Skill Enhanced Programs till now, have conducted 3 such programs for not only PGs, but member surgeons all over India. The first one was upper GI endoscopy and colonoscopy basics. The second one was therapeutic upper GI endoscopy. And third was advanced endoscopy, which included third space endoscopy lecture delivered by Dr. Nageshwar Reddy, cholangioscopy lecture delivered by Dr. Amit Mahadev. We had a beautiful lecture by Dr. G.V. Rao on marriage of laparoscopy and endoscopy. And finally, endoscopic ultrasound in surgeon's practice was also delivered. It is nice that ASI has taken lead as well as the state chapter like Jharkhand, who has now involved itself in propagating endoscopy. I know that in the state of West Bengal, especially city of Calcutta, Dr. Desarkar is doing excellent work. Dr. Midha is also doing excellent work in this. And this will lead to more and more surgeons taking up at least upper GI and lower GI diagnostic and minimally therapeutic endoscopy, which is very nice because I think it has always been armamentarium of a surgeon. So all the best. And as president of ASI, I would request Jharkhand state chapter under the leadership of Arunima and Sunil Kumar to enroll as many delegates as possible for the forthcoming virtual ASICON 2021 to be held in December. Also, as a president, it's my responsibility. Siddesh has already talked about it. The elections are around the corner. Please see to it that as many as people, member surgeons as possible, vote during these elections. And at the same time, let Jharkhand state chapter have the best of the people to represent Jharkhand so that Jharkhand comes up in future. With these few words, thank you so much. All the best, Arunima. Thank you.
Thank you so much, sir, for those encouraging words and also the guidance. Thank you very much for sparing your time. And now, without any further delay, we would like to go ahead with the scientific program. And this is just a screenshot of the scientific program that we have. I would thank all of you for joining us on behalf of ASI Jharkhand chapter and Surgical Vidyapeeth. Each member who has also logged in also, I thank you, because only with their participation can we really make this program a success. Because the dream is big. It's not just an online program. We would like to move ahead with giving hands-on training as well. But only with the response can we move ahead with this program. And as Abhay sir said that this was the armamentarium of surgeons. We, as far as Sunil sir and I am concerned, we have faced it and we have really struck back hard to the gastroenterologists not to give it away on a platter. So this is again an attempt that let us again come back and take this back as our armamentarium. Thank you very much, all of you. And I would now ask Satvir to start the scientific session. Sunil sir? We have 7 minutes left for the scientific deliberation actually, but can we start?
Yeah, it's in between we can have little, because sometimes it gets delayed also few minutes. So because we have Sunil Popat there, so that's fine, and yes, he has to go somewhere as well, so that's okay.
Right.
Siddesh is here. Third speaker is myself, so that's fine.
Right, sir. So we go ahead.
A very good morning to all of you. I am Dr. Satvir Singh from Hazaribagh. On the behalf of ASI Jharkhand, I welcome all the dignitaries and delegates for this program. To start with, I would like to say a saying from Guru Granth Sahib, which says that Guru bin kor andhar, Guru bin najar na aave. This means that without a guru, your life is dark, and without a guru, you are unable to see anything. And I am blessed to have so many gurus present here to teach us, to show the light of endoscopy for the surgeons, and hope we achieve great heights by these learnings. Thank you very much. To start with, our first speaker is Dr. Sunil Popat sir, and sir will be talking about colonoscopic polypectomy. And we welcome our esteemed chairpersons, which are Dr. K.K. Singh and Dr. Nalini Kant Chaudhary. Dr. K.K. Singh is Associate Professor Surgery from Palamu, Jharkhand. Welcome, Dr. K.K. Singh, sir.
Thank you, welcome.
And I welcome Dr. Nalini Kant, sir. Sir is a consultant surgeon from Bokaro. And sir have been serving Jharkhand from a very, very long time. And he is a very academic person and a lot of things to be learned from him. And I request, sir, to please welcome Dr. Sunil Popat, sir.
Hello, good morning, everybody. I would like to welcome Dr. Sunil Popat for the first lecture. He doesn't need any introduction, but I'd like to say a few words about him. Dr. Sunil Popat has been a leading gastroenterologist and a laparoscopic surgeon of Gujarat, and has a rich experience of 23 years in the field of gastroenterology. He is an honorary gastro and laparoscopic surgeon to His Excellency the Governor of Gujarat, and is an honorary visiting professor in the Department of Surgical Gastroenterology of GSL Medical College and General Hospital at Raja Mahendravaram, Andhra Pradesh. He is also an honorary secretary of Indian Association of Gastroenterology Endosurgeons 2018-2020. The other Dr. Nalin, would you like to say something? Or we can ask Dr. Sunil to go ahead with his lecture. Thank you.
Thank you. Can I share my screen, please?
Yes, sir.
Thank you, chairpersons, for the kind words. And thank you, Dr. Sunil Kumar, Dr. Arunima, and ESI Jharkhand chapter for this wonderful welcome and giving me the opportunity to talk about the endoscopic polypectomy for colonic polyps. I bring greetings from IAGS as the President IAGS and from Nidhi Hospital, Ahmedabad. In 1960, NIVA developed the first colonic camera, and first snare polypectomy with diathermy was done in 1969 by Hiromi Shinya and William Wolf in USA. In 1983, we first had our first video colonoscope available from Welch in USA. Later on, the Japanese company took over Olympus Pentax Fujinon, and nowadays we have a variety of video cameras available. So very quickly, the polyps can be pedunculated and sessile. It can happen anywhere in GI tract, but most commonly in colon, stomach, and then small bowel. And polyps can be precarcinogenic, neoplastic, or non-neoplastic. Polypectomy is basically a procedure to remove the polyps. What is important for all of us, particularly the junior surgeon, to remember is that this procedure should not be taken lightly like any other therapeutic GI endoscopy procedure. This is one kind of operation being done through the natural orifice, and the patient need to be put at rest by conscious sedation. We would always prefer to have anesthetist in the endoscopy room taking care of the patient, and you need to have all the parameters available for general anesthesia. Now position. Now position is very important because you need to have proper position of the patient, position of the surgeon, position of the scope, and then later on position of the polyp. So like always, we start the colonoscopy in left lateral position. We identify the polyp, and then we make the position of the patient in such a way, either left lateral or supine, to make the polyp in a suitable position for polypectomy. The scope should always be steady, and too much torque should be avoided. Otherwise, it can switch back to its non-torque position and can cause damage. Be in a comfortable position to do the polypectomy. You need to have good accessories like snares. At least 2 to 3 snares should be available. A needle, 23 gauge needle for a submucosal injection, a clip, an endoloop, and biopsy forceps, and also one needs a Rothman's basket or a polyp basket. As I said, we try to keep the polyp in a position at 5 with the stock at the 5 to 6 o'clock position, so it becomes easy for the polypectomy. Change the patient position if polyp location is difficult, and keep the polyp at a short distance from the tip of the scope. You should always do bare minimum opening of the loop whenever you are opening up the snare, and gradually close it. Advance of the snare over the polyp using up and down control and torque. A snare is slowly tightened. Aspirate the air to reduce the colonic well tension. However, always maintain the colonic lumen. And after holding the polyp, tenting of the polyp to direct diathermy away from the muscle layer of the colon. Ensure safe tissue capture by moving the snare catheter back and forth. There should be free movement of the polyp relative to the underlying colonic wall. If concerned that the muscle layer is entrapped, loosen the snare, release it, and then retighten it. After encircling, aim to keep the polyp in the center of the lumen to limit the thermal damage to adjacent tissue. Transaction should be controlled as the foot pedal is depressed while snare remains tight. Prolonged transaction time may suggest entrapment of the muscularis propria. There can be increased bleeding reef, which is a pedunculated polyp, increased vascularity. There can be increased risk of perforation if too much of coagulation is used. If the time taken for resection is too much, then you need to release, you need to check whether you have hold the polyp correctly. Whenever you are seeing the polyp covering more than 1/3 of the circumference of the colon wall, they are more difficult to safely remove endoscopically, and one need to make sure that he or she is competent enough with a good facility to take care of this thing. Behind the folds, difficult resection due to location. Injection of the far side of the polyp near the edge of the polyp will raise the polyp towards you. Snare may then be more easily placed, and retroflexion may be used if it is required. If the polyps are near the dentate line, the squamous epithelium is very vascular and sensitive. Positioning may be difficult, or it may be more painful to the patient. In such cases, retroflexion and use of a gastroscope will help in doing the procedure successfully. Be aware about the periappendiceal polyps, because sometimes polyp may extend through the appendiceal orifice into the appendix. Periappendiceal mucosa does not elevate well when you are giving submucosal injection. Involvement of more than 50% of the appendiceal orifice circumference is a relative contraindication for a polypectomy due to higher risk of the perforation. When you are having multiple polyps for the polypectomy, start from the distal and then go proximally, because if you remove the cecal polyp first and then go on doing polypectomy of the distal colon, chances of giving away of that cecal polypectomy site and leading to perforation are higher. Submucosal injection is a very important. The needle needs to be inserted tangentially with a slight angle of 30 degrees to direct into submucosa and not into peritoneum or through and through. Non-lifting occurs when injection is not in the correct plane. It may suggest invasive carcinoma if it's already suggested by looking at the polyp. I'll show you now the video of a polypectomy. So here is a polyp in the left colon, and we are doing the submucosal injection of saline epinephrine 1 into 1 leg and some methylene blue. And we are starting from the far end and coming towards us gradually, as you can see. We want to lift up the polyp. Now you can see the polyp is lifted up sufficiently. It also reduces the vascularity of the stalk and the polyp because of the vasoconstriction due to epinephrine. Then we go around with the snare. one need to take care and go around the polyp properly. Do to and fro movement of the snare. You can twist the scope little bit right and left to adjust your snare. Then encircle the stalk and start applying current, and then gradually start snaring the polyp. So the snaring is almost getting completed here. And the snaring is complete, just like passing of knife through the butter. So we just gently push the polyp away from the stalk, and you can see there is no bleeding, clear cut on both the sides. And this is a sign that the polypectomy is done properly with the proper coagulation of the stalk. Then we take out the polyp with Rothman's basket and send it for the histopathology. Now this is another polyp. This is a pedunculated polyp. Here you will see this is an angry looking polyp, quite inflamed, and there is a long stalk. So in a stalk pedunculated polyp, we inject into the peduncle to reduce the vascularity, and then we go around it with a snare. One has to take care, and you need to use your surgical skills of maneuvering here so that you can go around the stalk properly. Gradually you close the snare. Make sure that you have not got the muscular wall of the colon inside the snare. Once it is closed properly, then this is the to and fro movement, and you can see only the polyp is moving, not the colonic wall. That signifies that the snare doesn't involve the colonic wall. And then we apply the current and do the snare polypectomy. We use endocut. Now here the stalk of the polyp is held by the snare. So we remove the polyp with the snare only. As you can see, it is coming out nicely. This is another polyp on the angle, as you can see. Again inflamed with small ulcers, patient had bleeding. So we identified the stalk, we gave the injection. The snaring is being done. Snaring is completed and we take it out with the Rothman's basket. The most difficult area of doing a polypectomy is the ileocecal junction. Here there is a large polyp on the ileocecal junction. So this is the palpation which I do with a biopsy forceps. Move the polyp, see all around where the stalk is, where it is attached to the mucosa of the junction. It is attached to the inferomedial part of the ileocecal ileal mucosa. We identified it. I injected it, and then going around with a snare. And now you can see we only have the ileal mucosa which is spouting inside the colon, which is holding this large polyp as a very short stalk, as you can see. The snare has gone around. We started applying the current. We use endocut here in almost all these polypectomy. We need to have a good diathermy machine. And as you can see, the color of the polyp is getting changed. It is getting more and more blue because the vascular supply of the stalk is now taken care by the coagulation. Need to have a good video endoscopes also to get you the perfect vision. Here you are getting almost histological picture of the polyp. And always resect slowly. Don't be in the rush. The polyp is getting more and more darker as the stalk is getting divided. And in between, we are doing the to and fro movement to see that how freely the polyp is moving. That gives you an idea about how much stalk is left. Now it is completely divided, and you can see the inframedial mucosal part is divided with it, no bleeding at all. When you are worried, or for the beginners, if you want to avoid bleeding completely, you can apply an envelope like in this video all around the polyp, just like you are applying this on the stalk. Tighten the envelope and then release the envelope. Once the envelope is released, it becomes very safe to do the snare polypectomy. One has to be aware about the potential complications. There can be bleeding. Bleeding is one of the most common complications. Post-polypectomy bleeding can occur immediately, or it can be delayed, can be reactionary or secondary, even up to 30 days it can happen. The immediate bleeding can happen in up to 8.5% of the polypectomies. More common with the pedunculated polyps. Polyps in the rectum bleed more frequently during or after polypectomy because of the abundant vascular supply. If it's an immediate bleeding, it's more common when using pure cutting currents. Delayed bleeding more common with coagulation currents. The trick is to use the blended cutting current. Bleeding is also more common after piecemeal resection or mucosectomy techniques. To prevent the bleeding, use submucosal epinephrine injection. You can also use envelope. You can also use clip placement for control of the bleeding. So like I said, hemoclips we can use after polypectomy for control of the bleeding. We can also apply envelope or injection, or if it's a diffuse site, very sessile polyp, large row area, then argon plasma coagulation, or even a gold probe for a smaller area. Perforation is the second most dreadful complication. Immediate perforation secondary to mechanical stress or barotrauma or as complication of electrosurgery is reported, and it's quite common in the early days of polypectomy practice. Be careful, learn the colonoscopy properly, learn the art of therapeutic endoscopy properly, to have proper equipments to prevent immediate perforation. Delayed perforation, minutes later due to insufflation causing pressure on the polypectomy site, hours to days later when necrotic piece of tissue sloughs off due to excessive coagulation. Avoid excessive coagulation to prevent delayed complication, delayed perforation. Risk of perforation is increased with flat or sessile polyps. Risk is also more in the ascending colon polyps, and blended cut is recommended over pure cut or pure coagulation. Once you have the perforation, it can present as immediate abdominal distension. Delayed onset of pain should lead to abdominal radiograph and or CT. A perforation is noted, if the perforation is noted during endoscopy and is small, application of an Ovesco clip or loop may be attempted if you are working in a high volume center with a senior experienced endoscopist around. And routine treatment like antibiotics and SOS, laparoscopy or laparotomy. I'm not going to play this video. This is just to show a small perforation. This is not a perforation because of the polypectomy, but a tiny perforation can be identified. If it is identified during endoscopy, can be easily closed with the Ovesco clip. To conclude, ladies and gentlemen, endoscopic polypectomy is a very useful and important therapeutic procedure. It requires good quality video endoscopes, essential accessories, well-trained endoscopists and staff. Should be done in a setup where treatment for complication like bleeding or perforation is available. Thorough assessment of the polyp, plan the procedure properly, and estimate endoscopic resectability before attempting on the polypectomy. Don't start the procedure if you are not sure you can complete the procedure. Position of the polyp, scope, the patient and nerve are very important, and always do proper positioning. Avoid complications, identify complication if it happens early, and treat adequately. Hospitalize the patient if the patient is symptomatic and do the needful. Thank you very much for your patient listening, and thank you very much for giving the opportunity.
Thank you, Dr. Sunil. Very nice presentation. Nalin ji, boliye.
Thank you, Professor Popat.
Thank you,
I
sir.
have seen a professor of ENT in Bhagalpur having heavy hemocrhagia diagnosed to be colonic polyp and was operated somewhere endoscopically in New Delhi. So really it is very interesting and as well as educative. Thank you.
Thank you very much.
Thank you, sir. So we move on to our next speaker.
I think Dr. Popat would be leaving because he has some other commitment. But sir, at present, we did not find any questions on YouTube or the chat box over here. So if there are certain questions, we would request you to answer it whenever you get time on the YouTube link.
Sure,
Thank
sure.
you very
Thank
much.
you. Thank you, Arunima, and thank you, Sunil, for the opportunity.
Yes, sir,
and
thank you.
wish you all the best.
Thank you so much, sir.
Thanks, Sunil. Thank you.
Please go ahead.
To move on to our next lecture, we have Dr. G. Siddesh. Sir will be talking about tips and techniques of ERCP for surgeons. And our esteemed chairpersons are Dr. Om Prakash sir and Dr. S.S. Chauhan sir. Dr. S.S. Chauhan sir is a professor and head now at Tata Main Hospital, and sir has a very good academic background, and I welcome Dr. Chauhan sir. And I request Dr. Chauhan to please welcome Dr. Siddesh sir.
Yeah. Good morning to all the delegates and the faculty members. Dr. Siddesh is the Vice President ASI and President-elect for 2021. He is a former professor and head of Department of Surgery at JSS Medical College, Mysore. He is an endoscopist, laparoscopic surgeon, and medical director at Sigma Hospital, Mysore. I now invite Dr. Siddesh to please deliver his lecture.
Thank you.
Welcome, sir. So please share your screen.
I have done, but allow me to share, na?
Yeah.
Please.
Yes, sir. Please try sharing your screen.
Yeah, I'll try now. Earlier it had happened, but anyway, let me see again. Can you see this?
Anand, can you just sort it out?
Can you see?
No, sir. It's not.
ಸರ್ ನೀವು ಶೇರ್ ಮಾಡ್ಬೇಕು ಸರ್ ಸ್ಕ್ರೀನ್
ಮಾಡಿದ್ದೆ ಅದು
ಹೌದಾ ಸರ್
ಇನ್ನೊಂದ್ಸಲಿ ಮಾಡ್ತೀನಿ ತಾಳಿ
ಮಾಡಿ ಸರ್ ಮಾಡಿ
Has it there now?
sir yes sir done
Okay, that's fine.
view show ಮಾಡ್ಬಿಡಿ ಸರ್
Okay, that's fine.
Done.
Yeah, thank you for this opportunity without wasting time, because it is a very tightly scheduled program. So I need to respect that. So, and I understand this is purely a technical lecture. I don't want to go into the details of the theory, but so I will confine myself to the technique of doing ERCP. And I know there are a lot of experts around here. Mida sir is there, and Sunil is there. And I know a lot of people also are trying to pick up these skills. So I hope this lecture would be inviting more interest. Now, I would be failing in my duty if I don't thank my gurus, Dr. Shrikande, Dr. Nande, and of course I had opportunity to meet these stalwarts, Dr. Sohendra and Ligori, professors, stalwarts in endoscopy in the early years. You can see this, how ERCP used to be done in the earlier years in 85. See the handheld camera and the eye viewing endoscope. That was more difficult than how we do it today with a video endoscope. That much stress and strain on the body of the endoscopist has come down. But at the same time, more newer techniques and more newer procedures are being performed through the endoscope, including ERCP. So ERCP, or endoscopic retrograde cholangiopancreatography, is a procedure, as Sunil put it earlier, it is an operation done through the endoscope. Why it is very important to understand this term is it has so much complexities associated with this procedure. And we need to know what is the setup which is minimum required to perform an ERCP. We require a side viewing duodenoscope, which is different from the regular scope, I'll tell later. A SIOM image intensifier of good quality, so that you can pick up the very minute 0.018 guide wires on the screen. So it needs to be a short image intensifier, and we need to have an array of accessories. Here, these accessories can range anywhere depending upon the procedure which you are going to perform. And as Sunil Popat was telling earlier, we need to have accessories ready to counter the complications which may encounter during the procedure as well, like injection needles, clips, Ovasco clips. If you have availability, it will be add to your safety. So these accessories, not only we need to have them, we need to have many of them in multiple numbers, because during the procedures, like guide wires, sphincterotomes can start getting malfunction. So you need to replace them and start with newer accessories. So ERCP is not a cheap procedure, but we have to keep in mind as surgeons the cost of the procedure less by judiciously using these accessories, so that we can perform more number of procedures. Though they are meant to be disposable, we do use them repeatedly with proper cleaning and disinfective procedures. We need to have trained assistants, and of course anesthesiologists should be there always as a during the procedure, not only to maintain the airway, but to keep the patient sedated with conscious sedation techniques. ERCP steps I will be covering, like patient positioning is important. Most of the people perform the ERCP in prone position, but I tend to perform the ERCP, most of them, in supine position. I feel it is advantageous because the anatomy of the cholangiogram on the screen will be a replica of the normal anatomy, and I would be able to see the patient on the face and I can interact when the patient is, and also the anesthetist feel comfortable to control the airway. Whenever it is required to intubate, they may, this position will help them to do that immediately. So as I told, anesthesia is usually conscious sedation. Many perform ERCP routinely in general anesthesia with intubation, total control of the airway. So that is by choice, but we perform most of them with conscious sedation only in complex situations where we anticipate problems. Intubation is done. Scope position is, I'm going to talk a little bit later in detail. It is very essential to have the scope in a proper position. So not only to have a good visualization of the papilla for helping cannulation, but also to have a control on the tip of the endoscope by shortening the loop, which I will tell you. Cannulation techniques are to be mastered over time. There is a learning curve. An expert endoscopist is one who can cannulate excess of 90% of the times a successful selective cannulation of either the bile duct or the pancreatic duct. Contrast injection and getting a picture of the either cholangiography or pancreatography is the next procedure. And depending on the pathology which we pick up in the image, one need to plan out the procedures which are going to be performed later. Papillotomy is done most of the times as a precursor to any endotherapy done on the biliary tract or the pancreatic in most of the situations. And I will tell you more about this later in this. Now coming to few words about ERCP. As I told earlier, it's a highly skilled procedure. There is a learning curve. We need to go through a proper training. Surgeons always have an edge because we have a good knowledge of the papilla, biliary tree, as well as the electrobiophysics. You know, we are frequently, day to day, we are using the electrical surgical diathermy. Adaptability and quick decision making are absolute essentials in ERCP, like any surgical procedure. And complications, one need to be aware so that we can look for those complications during the procedure, and we can change or modulate your procedure and also do to treat those procedures during the endoscopy itself or later. Concept of using needle as a knife is more frequently more comfortable with surgeon's hand. And a decision on certain situations of the pathology can be done more freely by if your surgeon is doing ERCP. This is one of the basic anatomy of an endoscope which is used. It is a side viewing duodenoscope. It is nothing different from the regular endoscope, but for the fact it has additional, you can see my thumb on the elevator knob, which is present. At the same time, at the tip of the endoscope, you can see the light is coming out from the side of the endoscope and not the tip of the endoscope. So that is why it is called as a side viewing duodenoscope, not a conventional diagnostic endoscope. So that's how it is. Then we need to know the accessory channel is also on the side, by the side of the eyepiece, which allows the accessories to come out under vision, and they can also be elevated or depressed. You can see, and especially a wire guided sphincterotome is the most important tool in the initial ERCP technique. You can see the various angulations which can be achieved by not only bowing of the sphincterotome, but also by the elevation of the knob, which I showed earlier, by altering the angulation of the elevator. So this will help us, and this is how the angulation of the sphincterotome is performed by the assistant's hand. You can see that. So that's how angulation can result in various degrees. How position of the scope is very important. When you intubate the duodenum deep down into the D3 with the scope, this scope makes a big loop in the stomach. By that, if you try to cannulate, you will get into a wrong position. Hence, it is very essential to shorten the length of the scope. The scope length in the stomach should be shortened so that the papilla comes head on with the side of the duodenoscope, so that you have a better control on the tip of the scope, and also that the cannulation becomes in the correct angulation. See, that's what you can see in the radiograph, which is being shown. At the same time, it is very essential to understand, I'm not going to go into the details of the anatomy, but we need to know the basic anatomy, and which I want to stress is the fact that the bile duct goes upwards and to the left from the papilla, whereas the pancreatic duct goes more horizontally and to the right. So this is one thing we need to know. And another thing is that there are 3 sphincters which are there at the papilla. One is the common sphincter for both the ducts, and then there are 2 different sphincters for 2 different ducts. So we need to know about this. Accidental damage to pancreatic sphincter can result in bile reflux and post-procedural pancreatitis. So we need to know about it. So this is another diagrammatic picture which shows that when you are attempting at a selective cannulation of the bile duct, the direction of the movement of the papilla tome should be from 5 o'clock to 11 o'clock position, and in case of pancreatic duct cannulation, from 7 o'clock position to 2 and 3 o'clock position. That will simulate, the direction of the anatomy of these 2 ducts. We need to follow them so that we can achieve. So this is another picture diagrammatic. We need to know, after positioning the scope and distending the duodenum, one can think of cannulating selectively, and this is achieved by, see, the bending of the sphincterotome and a wire guide which is passed through and which is monitored on the fluoroscopy that the guide wire has gone in the right direction, and then it is followed up by the cannulation of the sphincterotome. So that's how, and then after confirming that you are in the selectively cannulated the desired duct, you can inject the contrast. So, and later on we can bow the sphincterotome and do the sphincterotomy. So this is how, and any person who is planning to do ERCP should be having knowledge of the anatomy of the biliary tree and also the various pathologies, how they appear after injecting the contrast. So without which one cannot plan the therapeutic procedures. As you all know, ERCP is no more a diagnostic tool. It is only aimed at therapeutic procedures, because ERCP has got inherent complications, and we have other modalities of investigation to visualize the anatomy of the biliary tree and the pathology. So these are the different pathologies one should be able to pick up when we do ERCP, and depending upon these pathologies one has to plan. And the commonest procedure one has to perform would be an ERCP and stone extraction, which involves doing a sphincterotomy in various stages and do balloon sweeping to retrieve the stones, as it is done in this case. And I have to demonstrate the same procedure which was depicted diagrammatically earlier. I'm trying to show here a selective cannulation being achieved through a wire guided sphincterotome and bowing, and after having a deep cannulation and a cholangiogram, the sphincterotome is withdrawn. The guide wire is still kept high up in the biliary tree, and bowing of the sphincterotome is done gently, and electrosurgical current is applied, and an endocut which is used in the right format is done. And by changing constantly the direction of the cut by body movement and angulation change of the scope, one can direct the cut towards the 11 o'clock position, which is to the bile duct. So this is a biliary sphincterotomy we performed, where both the common sphincter and biliary sphincters are cut, which is followed by instrumentation of balloon sweeping, which can result in stone extraction. Whatever the way we do in ERCP and stone extraction, either by balloon sweeping or by, you can see, by Dormia basketing, at the end of the procedure, one has to do what is called as occlusion cholangiogram by inflating the balloon and drawing to the end of the bile duct and injecting the contrast to know that you have cleared the bile duct of all the filling defects. Then we need to place a stent depending upon you are wishing to place. In most of these circumstances, one will be able to achieve clearance of the bile duct, but there are certain difficult situations where one can find it difficult to clear. So we need to do certain different procedures in these. I would just take a couple of minutes to describe So we may have to use a mechanical lithotripter to crush the stone to decrease the size of the stone. Then this is one of the methods which is being done here, which is by using the Sohendra mechanical lithotripter. But at the same time, sometimes see such large stones, you can see the diameter of the scope is around 13 millimeters. You can see the size of the bile duct is more than 2 centimeters, and the size of the stone is almost 1.8 to 1.9. And they have been crushed by the mechanical lithotripter, and pulverized stones are cleared of the bile duct. But you may encounter certain catastrophes like this, where the basket can break. So we need to be careful. There are other techniques of extracting large stones by doing a balloon sphincteroplasty, like in this situation, where large stones can be extracted. In difficult situations where initial cannulation is not possible by wire-guided sphincterome, one can use a technique called as needle knife sphincterotomy. Many a times, needle knife sphincterotomy can be the initial method of choice, like impacted stone in the distal bile duct as well. So you can see one of the patients where needle knife sphincterotomy is being performed. You please observe the direction of the cut is towards the 11 o'clock position. So such a bulging papilla is really an inviting papilla to start with needle knife and not with a sphincterome. And that's what I prefer. And I call needle is my knife and pre-cut is my passion. So one need to master this technique as endoscopist, and it has its own learning curve. One need to learn that the needle has to be used in cutting the layers by layer and in the direction, so that one will not cut and do perforation or inadvertent cut of the pancreatic duct as well. So this is how it is being done. You can see this. After that, one can do the balloon sphincteroplasty. How it is done, I just want to show in this video. CRE balloon, controlled radial expansion balloons can be used, and we can expand up between 12 to 15 millimeter diameter, so that large stones can be retrieved later. So this is one more technique. I will cut short one more video, and then this is one more case where a large stone was impacted in the distal bile duct or close to the papilla, where needle knife sphincterotomy is being performed to extract the stone. It is really a joyous moment when you see that the stone gets disimpacted and comes out, and which is followed by a gush of infected thick bile, which really causes, it is like relieving a patient of an abscess. And this is one video I just want to share with you, where I had done a laparoscopic treatment of hydrated disease, following which the patient developed within a week an obstructive jaundice, where on evaluation there are filling defects in the bile duct, and you see on sphincterotomy and clearance of the bile duct, what we got is the debris and the hydrated sand and daughter cysts. So there are certain difficult situations in ERCP which are related to anatomical issues. We need to understand them, and we need to be ready to counter this with different techniques. I don't want to go into those details. At the same time, stent placement is commonly done in most of these patients after having biliary therapeutic procedure, especially whenever there is cholangitis, when there are strictures, and in malignant obstructions. Various types of stents are being used. Most of them are made of these rigid plastic stents, or they can be flexible, self-expandable metallic stents of various shapes and sizes, and in construction as well. They may be covered or uncovered. So in certain situations like bile duct stricture, we use multiple stents to keep the stricture expanded, and these patients may require repeated procedures and repeated visit to the endoscopic treatment. And sometimes we have to use, for palliation of the growth, a self-expandable metallic stents as well. Pancreatic stenting is required to treatment of strictures, treatment of pancreatic fistulae, ductal leaks, and transpapillary drainage of a pseudocyst. So one need to know about these techniques when you do this. pancreatic stenting has a different technique and slightly different in cannulation as well. I don't want to go into these details. Complications of ERCP, I don't want to touch because it's going to be covered later on by Arunima. So thank you very much for this opportunity. I am open for discussion and any comments. Thank you.
Thank you very much, sir, for that brilliant presentation. And we have some questions. One question is to you directly that, sir, do you do MRCP for all cases before proceeding with ERCP? As you mentioned earlier, ERCP is no more a diagnostic tool.
Absolutely. Very good question. See, it all depends on what is your clinical diagnosis and also good ultrasound scan if you have it in hand with an altered liver function, a dilated bile duct and the obvious stone in the bile duct, I would straight away go and do ERCP and clear the duct instead of, because anyway, to clear the bile duct stone, we need to do an ERCP. So that is one thing. If there is no obvious stone seen on ultrasound scan, if the liver function test is not very conclusive, then we need to do an MRCP. And of course, another restriction is the cost and availability of MRCP. Of course, today, MRCP is available in large number of centers and it is becoming cheaper as well. One has to depend on MRCP whenever is required. And it is better to err on the side of overdoing these investigations than underdoing, so that you can plan your procedure of ERCP better than doing it blindly.
So just in addition to this, that there might be, nowadays, most of the pacemakers are MRCP compatible, but if a patient has those implants which are not MRCP compatible, if a center does not have a EUS, would you still, what would you do? You would go ahead with ERCP in that situation?
Yes, yes.
Okay, and sir, this is a question I think any one of the faculty can take it. It's basically because we are trying to encourage surgeons to take up these procedures. So a question is, can general surgeons with proper training perform ERCP and have a setup with MS surgery degree only? Or is there a need for some additional qualification or degree in ERCP or gastroenterology?
I think it's a fantastic question, Arunima. I think this has to be talked in a much bigger platform at our ASI level. We are addressing this. See, diagnostic endoscopy, I don't think anybody who has gone through a formal training without an additional qualification can go ahead and do next day. If he's feeling, if he has a good adequate infrastructure, should do it. Whereas when it comes to therapeutic endoscopy, especially ERCP, we need to have some sort of a certification. It is not a must legally bound thing. Like I didn't have a written thing before I started doing ERCP in 92, 93, when I started doing my first ERCP. But today, there is so much of awareness, and remember, there are parallel branch which is practicing therapeutic endoscopy by qualification, with qualification. So we need to be a little careful here. We need to have a certification minimum basic required from an authentic institute where they are routinely doing this procedure. I think that is my opinion, than just starting offhand. Just because you are trained well, you cannot just start. Thank you.
Right. So I think in the previous session, I did speak about training for endoscopy in surgeons, and I did mention about having a, format and a structured training where there has to be, you have to get accredited. But unfortunately, sir, I think we still are lacking for institutions where we can have such training. And I think that's another thing we have to popularize through ASI. Thank you very much, sir, for this wonderful presentation and the guidance. And Satvir, yours.
Thank you, sir.
Thank you. Thank you.
We move on to our next speaker, who is Dr. Sunil Kumar, sir. And sir will be talking about how I do ERCP. And our esteemed chairperson is Dr. Jugal Kishore Chaudhary. I would request Dr. Jugal to please welcome Dr. Sunil, sir.
Welcome, Dr. Sunil, our EC member. I also welcome all the dignitaries on this virtual platform, especially our ASI President, Dr. Dalvi, Dr. Siddesh, our Secretary, Dr. Jain, our past President, Dr. R.P. Srivastava, and other members. I welcome you all from the land of Dr. Vednath Dham, Baba Vednath. I hope you are all in good health. I request Dr. Sunil to proceed.
Thank you, Jugalji.
Please counsel.
Anand, can I share my screen now?
Yes, sir, please.
Yes, sir. You can share, sir.
So thank you very much. In the next 10 minutes or so, I will be talking about how I do ERCP. There would be certain overlap and there is a purpose behind it. Out of all the training, whether in India or England for more than 10 years, whether it is GI cancer surgery, laparoscopic surgery, I found the training of ERCP technically most demanding. So even if there is an overlap, I really want that surgeons should take at least basic therapeutic ERCP because it's a therapeutic module now. And I'm happy that in Jamshedpur, after me, Arunima is well trained to do ERCP, and she has started doing ERCP in Tata Motor Hospital. I understand they are going to get new instruments, so she'll be doing more and more. So ERCP, this is the picture of a teamwork with nursing staff, anesthesiologist, my DNP trainee, when I was in Tata Main Hospital in Department of Surgery. And you need a good team conversant with every procedure. ERCP basically is the endoscopic visualization of upper GI tract and a radiological evaluation of the biliopancreatic duct. It's an advanced endoscopic procedure. And it has got complication which will be dealt with by Dr. Arunima in time to come. As they said, it's a side wing duodenoscope and its objective lens is situated at the tip. So there are indications because without indication, ERCP should not be done. As Siddesh rightly mentioned, wherever there is a doubt about the diagnosis of CBD pathology, MRC is the way forward. If the index of suspicion of finding a CBD pathology needs therapeutic intervention in more than 80–90%, so we can go ahead and do the ERCP. Like if there is a, say, biliary fistula, so that needs a therapeutic stenting. Now say there is a patient with a gallstone, with obstructive jaundice, altered LFT of obstructive pattern, history of cholangitis, presence of CBD stone ultrasound. So they don't need MRCP because the diagnosis is made. But sometimes you can get a situation where the patient has come with a gallstone pancreatitis, with minimal alteration of LFT or a normal LFT, normal biliary on ultrasound. So suspicious of CBD stone is there, but it's not that much. So these are the subset of patients who require MRCP. And if you do find that CBD stone is there, then they would need a ERCP. We need a good setup in ERCP to achieve a more than 90%, and that is what the requirement is these days, to be a good ERCPist. Patient position, commonly used accessories, we need to be conversant with all sphincterotome, guide wires, ERCP cannula, and it's important that we have a technical know-how, not you only as a ERCPist, but all your team, whether it's a nursing staff, your assistant, your trainee, every set. So it's a good idea to spend few weeks going through all these instruments. And it's very important to prepare the patient for ERCP, whether it's a pre-ERCP investigation, consent, antibiotics, positioning. And these are the various steps which this has already talked about. But even at the cost of little repetition, I will just give a little bit of helicopter view because ERCP is less done by the surgeons. And now surgeons are doing more and more upper GI and even colonoscopy. We should really push hard that surgeons should also take up because after all, gallstone and CBD stone is a surgical disease and should be managed by surgeon. And it's very important that ERCP also comes into the armamentarium of the surgeons. So I know as we intubate the duodenum, ampulla of Vater is seen. This is appears very easy, but cannulating the CBD or ampulla of Vater or even finding the papilla is not easy task. And you need to know the little bit of anatomy of major papilla, which has 4 distinct parts: papillary orifice, frenulum, hood, and infundibulum. And sometimes there can be variation. Infundibulum may be large, small, or even absent. Or there may be a periveterian diverticulum, which can be liable for perforation if you're not careful. So presence of periveterian diverticulum makes the ERCP procedure more difficult. And this is how we do in the ERCP. We need to be knowing the maneuvers. It's just like driving a car. Once you get trained, memorize the step, go through under supervision, then it becomes a kind of automated reflex action. But it is very important that all this training is based initially with the knowledge and then simulation and then continued training. This is a little small video clip to show that how we have been doing ERCP in Tata Main Hospital. The first and foremost, after all this position, necessary preparation, instrument all being checked, the first is the esophageal intubation. It is usually a blind intubation, but it's not very difficult. Then get into the gastric intubation, where you can recognize the stomach by the gastric rugosity. You can see the bile coming through the pylorus opening. It does mean that you are on the right track. You can see the pylorus inferiorly. And once you are there, next is the duodenal intubation. As you see, I can see that the ampulla of Vater with the little orifice is popping and seeing you. In this case, there was a small little periveterian diverticula. And because there is a peristalsis, once the duodenum is intubated, usually an ampoule of hyoscine is given to make the duodenum little quiet and for you to successfully cannulate the papilla. We have been doing most of the CBD cannulation. I did not do much of pancreatic stenting. And this is a ERCP cannula and wire guided cholangiogram. I learned it. I also used to do sphincterotome guided, but this is the time when I got this video. Cholangiogram is more or less vertical. On the left side, you can see the pancreatogram, little on the right side, crossing the vertebra. And sometimes ERCP cannulation can be difficult, which is usually due to patient-related factors, obese patients, restless patients, but mostly it is done under conscious sedation or under propofol. Sometimes the endoscopist factor is also there, lack of training, or your team is not trained, equipments are not great. So it's all combination. To achieve a good quality ERCP, you need a combination of a structure, combination of process, and then only the outcome will be better. These are the standard techniques: guide wire assisted, contrast guided. And this is my last slide to give you a little inkling that you need a good setup. This was Tata Main Hospital when we were doing CR. Most of people, you can see the trainers, trained anesthesiologist, technician, patient's positioning, monitor, everything. So it's a whole combination. So a very dedicated team is necessary to achieve a safe ERCP. I'm sure Arunima will be talking about the complication, because ERCP, if not performed properly, and can lead to complication, and it has the propensity to kill people. So it doesn't need to be taken lightly, but once we are trained, there is a little bit of volume. If you're doing more than 4, 5, 6 ERCP in a month, with the background of it's all right. This is the papilla going in the 10th to 11th position, cannulating. It's a deep selective cannulation of CBD. And once the contrast is given, you can see the nice cholangiogram is achieved. You can see the right hepatic duct, left hepatic duct, nicely delineated. You can put the guide wire. And in ERCP, I always used to tell my trainees that God gives you only one chance. Once the guide wire is in the CBD and something happens, the patient bucks up or it's pulled out, it goes into a spasm, then it's becomes very, very difficult. So we must be very careful. This is the sphincterotome, the bowing of a sphincterotome. You can achieve up to 1 centimeter, 1.5 centimeter. You can see that on the top there is the transverse hood. You can go up to that. Now people with the training are becoming more and more bold, and even 1.5 centimeter stone can be extracted. As it there showed, you have a balloon to do a sphincteroplasty that can increase the diameter of papilla. This is the balloon swapping. In times of indication, people can put stent. Usually the 10 French stent is the one which is required if the CBD stone clearance is not 100%. And a stent can be left for 4 to 6 weeks. It lowers the biliary pressure and helps to drain the bile, not only through the stent, but also from the side of the stent. So nice, you can see the bile coming through. So with this background, I really want that ERCP is a very, very good technique, and it can save life, because in a patient who has got cholangitis, a stenting can save life. Otherwise, cholangitis is one condition, very bad suppurative condition, can lead to toxicity immediately. So to conclude my talk, biliary cannulation directly affects the success rate. It's one of the major steps of ERCP. There are both commonly known and rarely used techniques. It's important to know when and how to perform alternative methods. And if cannulation fails despite all the above methods and techniques, referring the patient or abandoning the procedure is a very good escape route. With this, thank you very much for patient listening. Back to Arunima and Satvir.
Sir, thank you very much for that wonderful presentation. It did take me back to memory lane when we were working together as a team. And yes, we have done multiple cases, very difficult cases of ERCP together. And there's a question also on teamwork. So it does remind me of our team, definitely. So a question is that, as you have rightly said, that it's a teamwork. What is the percentage of failed ERCP with good setup?
See, a good ERCP should be able to achieve 95% of cannulation. They are saying now even 99, but that possibly they should do. But I would be happy if I achieve more than, and that is what we have been doing. More than 92% has been our strike rate. That's something which to aim for.
No, I think Sunil, can I just answer this?
Yeah, please.
Say, the point is what Sunil has told is absolutely correct. We are not, see, the more than aiming at cannulation on every patient, we need to be safe. If there is a difficulty, you can do a needle knife or a pre-cut and leave it there, come back on another day after 48 hours and make another attempt. So use another technique instead of go on doing so that your cannulation rate always remains 100%. So that is not the way to look at. We need to be having a safe patient than achieving my rate is 100%. So
Yeah, that's true. I agree. What basically I wanted to mean that a good ERCP should be able to achieve around 90% successful ERCP, keeping the safety, patient safety as the foremost.
I would just like to ask a question to Dr. Siddesh, because he pointed out a very important thing, that instead of persisting and having complications, which is my topic, Sir, when you take up a patient like after 48 hours, this is not a very technical question, but would you charge for it separately again, or would you put it in the same charges?
Well, it is our practice that when you have spoken to the patient as a package, it becomes very difficult for us to convince him to pay for the second time. But usually what we do is we charge the patient for the diagnostic procedure and the anesthetist charges. We won't charge to the hospital and the endoscopist, and we have another opportunity as well. But we need to be careful to preserve the accessories. In the first attempt, you go on doing already you lost a sphincterotome, you have lost a guide wire, then the cost gets added. Somebody has to pay for it, isn't it? So that's where we need to keep on balancing.
Sunil sir, there's a direct question to you that what type of patients you want a new trained ERCP surgeon to choose based on ultrasound and MRCP report?
See, if the patient has a simple CBD stone less than 1 centimeter, that's the patient to go for. Dilated CBD, that's the patient to go for. But in the earlier training part, a surgeon should be able to tackle CBD stone and put a stent in the case of cholangitis, because that's a life-saving procedure. But as I said, it's a technically demanding. It's a persistent perseverance, continued training, reading, working in the center, and I'm sure everybody will be successful.
Right, sir. Thank you very much. And sir, many of our students are also there watching it on YouTube. And one of our students, Shavik Chandra, who was a part of this team and making that video, is there, congratulating you on your presentation. So
I know, I must tell Shavik, it was only he was assisting, and he has put that video on the YouTube many years ago. So that is the one which I keep showing Shavik.
Yes, sir. Thank you very much, sir. Satvir, over to you.
Nice, Sunil. You are keeping up the legacy. You have stimulated people. That speaks nice and volumes about you and your center.
Thank you. Thank you.
Thank you, Sunil sir. That was a very enlightening lecture. So we move on to our next lecture, which is on complications of ERCP by Dr. Anunima ma'am. And I would like to welcome our chairperson, Dr. Professor D.K. Sinha sir. Dr. Professor D.K. Sinha sir is from Department of General Surgery, RIMS, and sir has been an examiner, PG examiner to many students, and sir has many publications, and sir has been a controller of examinations of Paramedical Council of Jharkhand. I welcome Dr. D.K. Sinha sir and request to introduce Dr. Anunima ma'am.
Thank you, Dr. Satvir. First of all, I thank all the organizing team for organizing such a nice endoscopic deliberation. So far, Dr. Arunima Verma, he is known to me since very long. He is also a student of our institute. At present, she is head of department, Tata Motors Hospital, Jamshedpur. She has many qualifications, including MRCS, FSCS, FIAGS, fellowship. She is chairman-elect ASI Jharkhand chapter, editorial board member, Indian Journal of Surgery, 2019 to 2025. She is executive member of ABSI also. She is going to present a very important aspect of ERCP, that is complications of ERCP, which is very important. So far, therapeutic ERCP is concerned, which is now usually done. And for this, I think young surgeons will get much benefit when they know the complications of ERCP. So I request Aruna to start her deliberation. Thank you.
Thank you very much, sir, for that kind introduction. And definitely, I do remember I am also Dr. D.K. Sinha's student. So it's an honor for me to be introduced by him. Thank you very much, sir. And is my screen visible?
Yes, yes.
Yes, ma'am.
Right, sir. So I think there have been two very good presentations on ERCP, which has just paved way for my presentation. So what I'm going to speak over the next 12 to 15 minutes is about ERCP complications, which I think is a very important thing to be sensitized before anybody takes up ERCP, because your eyes will only see what your mind knows. So to start with, ERCP for the scopist is 1% frustration, 2% radiation, 3% inspiration and 94% perspiration. This is what has been said by Peter Cotton, who has written a very nice book on ERCP, the fundamentals. And I'm also showing these books so that people who are surgeons who are planning to take up ERCP can go ahead and read these books as well. So as surgeons, we all know that we would not want to have complications. We would like to prevent them, because no matter what cure you want to do, that would always be less than the prevention that you do. So prevention always outweighs the cure. So your operative management or any other management for post-ERCP complication should be the last resort. So what you need to do is do a safe ERCP. For a safe ERCP, a very important part is planning. So planning includes choosing the right patient. When you choose the right patient, you are going to be less landing up in complications. Also, plan your procedure much in hand. Look at your setup, everything. That has to be the part of planning. Then prepare. I think everybody should be aware that ERCP should be, I had also mentioned that most of the therapeutic endoscopy should be counted as a surgical procedure. So you should actually follow a checklist for them. So that you do not miss anything. So prepare yourself properly. And then monitoring. Monitoring is very important, both intra-procedure and post-procedure. So keeping these three in mind, you should plan a safe ERCP, which will prevent most of your complications. So looking at what complications ERCP can do, the common ones are pancreatitis, cholangitis, hemorrhage, and duodenal perforation. There would be less adverse events like cardiopulmonary complications, contrast allergy, impaction of a retrieval basket, and many other events, especially when you're dealing with tertiary care centers where you're taking up advanced ERCP procedures. There would be many more of them, which I'll definitely not be dealing with in this sensitization program, because we are dealing more with the basics and the secondary level care. So I would be dealing with more of the common complications. So there are multiple factors which are responsible for ERCP complications, like intrinsic risk of ERCP, patient selection, the skill of the operator, and complexity of the procedure. When I talk about complexity of the procedure, ERCP itself is a complex procedure, but Dr. Siddesh in his presentation did point out which are the conditions in which the ERCP becomes more complex, like Billroth 2 operation or any previous surgeries that have been done on these patients, which can make this procedure more complicated. These are various studies which were taken up to look at the ERCP complication, and if you look at it, the overall complication rate ranges from 5 to 10%. So I would start with a case scenario. This is definitely not a made up scenario. This actually has happened. This is one of the complications that I recently had, because I am right now working with a new team. It's an excellent team to say, because they are very enthusiastic, ready to learn, ready to change, but it's a new team for me. So it was a 64-year female with diagnosed polylithiasis and CVD calculi with comorbidities of diabetes mellitus, ischemic heart disease. She had a normal LFT. So we take her up for ERCP, and unfortunately, multiple times pancreatic duct cannulation was done and dye was injected. Pre-cut knife was used for sphincterotomy, because as Dr. Siddesh said, I did plan that, okay, maybe we can just do a pre-cut and come back later. Though we do have, those issues like charging the patient. It's a non-employee, so there are charges associated with it. So we did a pre-cut, and then in post-ERCP period, it's a routine that we send serum amylase immediately post-procedure, because post-procedure amylase is an important prognostic indicator that whether your patient is going to develop pancreatitis. So she had developed, she had a serum amylase of more than 1500 and a CRP of more than 100. And we did diagnosis at post-ERCP pancreatitis. So there are certain risk factors for post-ERCP pancreatitis. They will be patient-related, procedure-related, and operator or technical-related factors. So the patient-related is young age, female gender, suspected sphincter of Oddi dysfunction, recurrent pancreatitis, previous ERCP pancreatitis, and patients with normal serum bilirubin. Procedure-related will be multiple pancreatic duct injection, difficult cannulation, pancreatic sphincterotomy, pre-cut, and if you have done a sphincterotomy dilatation. Operator or technical related factors are inadequate training or inexperience and trainee involvement in procedure. So when this patient was concerned, there were multiple factors that were present, like she had female gender, she had a normal serum bilirubin, multiple pancreatic duct injection, difficult cannulation, and pre-cut. All these factors were present, good enough to lead this patient to develop pancreatitis. So just talking about a few of these, like multiple pancreatic injection, be very careful that you should not be injecting the dye at pressure, because that can cause hydrostatic damage, and that also leads to pancreatitis. So it should be a very gentle push of the dye. And nowadays, people are moving towards no dye injection when they are cannulating. It's just a wire cannulation that is being promoted to prevent this post-ERCP pancreatitis. Though that is a next level. Initially, when we start, I don't think everybody can achieve that level. That's the next level that you should achieve, that only a direct wire cannulation is enough without injecting any dye. She did have a difficult cannulation because I felt she did have an element of sphincter of Oddi dysfunction, and I did a pre-cut, as I said. So all these factors were present in this patient to have a post-ERCP pancreatitis. However, she recovered well and she has gone home with no complications as such. So for post-ERCP pancreatitis, the most common complication of post-ERCP is the ERCP pancreatitis, which is also called PEP at times. The mechanisms that lead to post-ERCP pancreatitis are complex and still not well understood. Post-ERCP pancreatitis should be suspected in any patient who develops pain within 6 hours of the procedure, because this is less likely to develop after 12 hours of the procedure. Amylase lipase greater than 1000 international unit is strongly suggestive of pancreatitis, and values greater than 276 for amylase and 1000 for lipase, which you obtain within 2 hours after the procedure. And that is why I said that we send the serum amylase immediately after the procedure. This is almost 100% have positive predictive for post-ERCP pancreatitis. But still, if you have a doubt, then you can go in for radiological confirmation. So how do you prevent post-ERCP pancreatitis? So for the prevention of post-ERCP pancreatitis, first you would know the high-risk patient, as I already mentioned. There is pharmacological prevention and stent and guide wire prevention. So pharmacological prevention, there are 5 categories of drugs which are being used and are being tested. They are still not, all RCTs are not available for these, but the first group is decreased pancreatic inflammation, like antioxidants, antibiotics, steroids, and non-steroidal anti-inflammatory drugs. The non-steroidal anti-inflammatory drugs have been found to be effective, and especially indomethacin has been said to be effective. And even when you're using rectal lignocaine, that also has said to have a protective role in development of post-ERCP pancreatitis. Now, the decrease of sphincter of Oddi pressure by use of nitroglycerin, nifedipine, botulinum toxin, the drugs that attenuate systemic inflammation like heparin, gapexate, ulinastatin, those that decrease pancreatic stimulation like somatostatin, octreotide, calcitonin, glucagon, and beta-carotene, and those that interrupt the activity of protease. These, none of them have been found independently effective, and more RCTs are actually needed to find out their role in prevention of post-ERCP pancreatitis. The stents and guide wires for the prevention of post-ERCP pancreatitis has been established, and at many centers, prophylactic stents and guide wires are being left, for especially in settings like sphincter of Oddi dysfunction, difficult cannulation, balloon dilatation, that is balloon sphincterotomy, and pre-cut sphincterotomy. There is a RCT going on that is studying between the role of, that is called the SVI trial, that is between stent and indomethacin, to look at the prevention, which is a better one to prevent post-ERCP pancreatitis. There's a picture that that is being seen in the slide, which actually is showing what I mentioned initially, that nowadays without dye, you should go in with a guide wire cannulation, and that is enough without without the dye. So when we talk about the treatment of post-ERCP pancreatitis, the treatment remains as for any other pancreatitis. And what is very important, as we know in the management of pancreatitis, is adequate hydration. And these patients, when you're planning, and especially if you have these risk factors of development of pancreatitis in ERCP patients, please hydrate them well before the procedure. And ringer lactate solution hydration before the procedure is supposed to have a kind of protective role. And hematocrit has found to be, because hematocrit gives you an idea about hydration. So maintaining the hematocrit in the normal range, again, is a good indicator as a part of your management. And obviously the other management, I would not deal with it. The rest of the management is as with any other pancreatitis, like it starts with conservative and may go on up to open necrosectomies. Now, this is a second case scenario, and I would say that this was the first duodenal perforation that I have had in the whole 10 to 12 years that I have been doing ERCP. This was a 58-year female with obstructive jaundice secondary to a periampullary carcinoma, suspected distal cholangiocarcinoma, with a serum bilirubin of 30 mg%. Her PT-INR was deranged, and after vitamin K and FFP, her PT-INR came to the range of INR was 1.6. She was planned for ERCP stenting because she was too sick to undergo any procedure, and this is what we planned for her. So ampulla was cannulated, and we just started sphincterotomy, which was a very difficult one, and there was sudden give way feel of the scope, and I immediately realized that there was a perforation. So this is the advantage of a surgeon doing a ERCP or any endoscopy, that I immediately converted that into a laparotomy, and we did repair the duodenum. We found a perforation almost 12 millimeter in the second part of the duodenum, and this was repaired. It was primarily sutured, and an omental patch was given. And I would talk about the perforation classification in the next slide. Unfortunately, she was a very sick patient. She could not make it. But this was one, and this has been a very big learning for me, that even after so many years, in my initial years, I did not land up with any of these perforations, but I did land up with this one. So I talked about Stafford classification, which was type 1 for the perforation that I talked about. So there is type 1, type 2, type 3, and type 4. So the type 1, there are multiple classification system. One is Stafford, one is Howard, and one is ENS. The most commonly used is the Stafford classification. The type 1 is a lateral or medial duodenal wall perforation, and is usually endoscope related. Type 2 is a periampullary perforation, which is sphincterotomy related. And type 3 is a ductal or duodenal perforation due to endoscopic instruments. And type 4 is the guide wire related perforation with presence of retroperitoneal air. These are the other types of classification. And when I talk about these perforation, what is very important, especially in the type 3 and type 4, is, they can be missed perforations. So recognizing the perforation during the procedure is what is very important. And this definitely is not my own slide, but it is a slide taken from the net. And what I can show you is that the wedge-shaped lucency, that is, very important. Don't miss it. This is what is showing that there has been a perforation, and you need to deal with that perforation. Obviously, it can be dealt with conservatively as well, but you need to recognize that there has been a perforation. So this is, I have picked it up from a systematic review of management and outcome of ERCP and related duodenal perforation. And when we talk about the management of ERCP related duodenal perforation, the incidence can range from 0.09 to 1.67 with a mortality of up to 8%. Early surgical intervention in Stafford 1 lesion has better outcome. As I told you that mine was a Stafford type 1 lesion. Unfortunately, it did not come out well, but anyways, that is what has to be done. And opposite is true for Stafford lesions 3 and 4. That is, you have to go in with conservative first. They don't need a surgical intervention. The most common type of perforation that you come across actually is Stafford type 2, that is in 58.4%. Type 1 is the second most, that is 17.8, followed by type 3, which is 13, and type 4, that is 10%. So as I mentioned, that early surgical intervention is going to be better for Stafford type 1 and 2. And also, if you have done that within 24 hours, then you land up with a smaller or simpler procedure, like some simple duodenal suture with or without the mentopexy in 93% cases. But if you go in late, that is more than 24 hours after the ERCP, then the interventions become more complex, and you might have to go in for, bypasses and everything. So earlier the intervention, the better it is. Once again, stressing on the fact surgeons have a better chance here again. So when we talk about endoscopic and medical management to start with, and here what I'm trying to show you is that the endoscopy has taken leaps and bounds. And here you can see endoscopic clips being used for repair of perforations. But definitely you need to be trained for it. These need to be available, or finally it is surgical. So I think this is the leap that gastroenterologists are also taking, that they are repairing the duodenal perforations with endoscopic clips. Again, there was actually also a question in the chat box. They wanted to know about bleeding in ERCP. So bleeding is one of the most frequent complications following endoscopic sphincterotomy and can occur in up to 5%. The rates of post-endo ERCP sphincterotomy bleeding may vary, and its presentation may be either immediate, that is, you may recognize it intra-procedural, or it may even present several days later. And the bleeding can range from insignificant to life-threatening. So the causes of bleeding again will be patient-related or the procedure-related. So patient-related, bleeding disorders or coagulation profile has been disturbed. All these conditions will lead to increased bleeding. When we talk about procedure-related, as I said, endoscopic sphincterotomy is the most common cause. There can be wire injury to CBD, and also the type of energy that you're using that can cause bleeding. So a mixed and blended energy always reduces the bleeding. So when we talk about the management of bleeding in ERCP, conservative management, especially when it has presented late and like hemophilia, so it has to be managed as GI bleeds. So I will not go into the details of it. What I will talk about is when we talk about the endoscopic treatment. So once you see this bleed while doing an endoscopic sphincterotomy, please do not stop the endoscopic sphincterotomy, complete the sphincterotomy. Why complete the sphincterotomy? Because if you leave it in between, then the vessel that has been cut, that will not go into spasm. So it will continue to bleed and there will be more bleeding. And once you have done a complete sphincterotomy, there is a chance of this vessel to go into spasm and the bleeding might stop. Then the next level can be that, you can give a mechanical, there are mechanical methods which have been tried. So the mechanical method is that you can put in the balloon, the sphincterotomy balloon, and inflate it, pull as you say, shorten the endoscope and leave the pressure for just like we do in surgery, the practice in surgery, tamponade effect. Give that tamponade effect. Give it for 5 minutes, come back and see, usually it should stop. Next is injection with adrenaline. Like we all know that even in upper GI endoscopies, we can give adrenaline injection in bleeding ulcer, and all the same thing is used here. You can inject epinephrine in the dose of 1:10,000 units. You can inject. That also causes, you can have thermal ablation and also clips that I showed over there for repair of duodenal perforation. So there are clips for control of bleeding as well. But after all this, if there are refractory cases, then you might have to go in for angiographic embolization or surgery, just as management of any other GI bleed. The next complication is post-ERCP cholangitis. And again, the post-ERCP cholangitis is not very uncommon. And this is one of the studies which includes more than 4,000 patients for a period of 5 years. And it found an overall complication rate of 9.4% with post-ERCP cholangitis 2.4%. And most dangerous time for having post-ERCP pancreatitis is within 24 to 48 hours after the ERCP procedure. 45% of these cases occur between this period. And the risk factors are age, that is older the age, hypertension, diabetes, previous ERCP history, biliary stent insertion, pancreatography, endoscopic sphincterotomy, balloon dilatation, and biliary obstruction. And on the other hand, when you have done an endoscopic stone extraction, it is a potentially protective factor because we all know that CBD stones can cause cholangitis. So if you have removed that, that is a protective factor. And the rest of dealing with cholangitis, rest you have to deal with as you deal with any sepsis, hydration, antibiotics, monitoring the patient, and depending on what stage of sepsis is the patient, you have to deal with it. I would just mention about an unusual complication, stuck Dormia basket, because there have been multiple case reports of impaction of Dormia basket while removing stones. And though it is an unusual complication, it's a very important one because many a times when gastroenterologists are dealing with it, they have no other resort except to cut the basket, send the patient to a surgeon, because this is not something that they can open up. For a surgeon, the advantage again is that you can open up and take it out, but it does deserve an urgent resolution, whoever does it. There have been reports of even laparoscopic CBD duct exploration and taking out the dormia, but I think it all depends upon the expertise. There are multiple endoscopic methods also which are coming up. So here what you need to remember is, why does the dormia get impacted? There are a few things which you should avoid. Trying to take out a stone more than 1 centimeter, be very careful because your sphincterotomy usually goes up to 1 to 1.2 centimeters, and any stone bigger than that has a very high chances of impaction of the dormia. So usually you should have a lithotripter to deal with such stones. Still you can have a dormia impacted, but still at least this is one thing you should avoid doing. So when we talk about prevention of complications, one very important thing, choose your patient rightly. And remember that ERCP is most dangerous for people who do not require it. So if you are having these indications for which you are thinking of ERCP, please do not do it. For vague abdominal pains, pre-lap chole, isolated bile duct and pancreatic duct dilatation, isolated increase of amylase lipase, non-availability of MRCP and endoscopic ultrasound. Avoid doing it. Choose your patient rightly, work them up properly, prepare them properly. And before I end, I would just again make a mention that by talking about all the complication, I'm not dissuading any one of you, because this is Atul Gawande is a surgeon who has written a very nice book on complications, a surgeon's notes on an imperfect science. So no matter what measures are taken, doctors will sometimes falter, and it isn't reasonable to ask that we achieve perfection. What is reasonable to ask that we never cease to aim for it. So what I would suggest is that all of us who are aiming to take up endoscopy, therapeutic endoscopy, ERCP, first fill up the gap between your knowledge and your skill. Get the knowledge, acquire the skill, choose your patient right, and please go ahead with doing the procedures, because we all became surgeons knowing that we would be dealing with complication. The only one way of not having complication is not to do the procedure. So I'm sure none of the surgeons would want to do that. So we would continue to do procedures, continue to have complications, know how to deal with it, accept it, avoid it. Thank you very much for your patient hearing. And I'm ready to take up questions if there are any.
Yeah, there is a, Purnima, there is one, before I hand it to Professor Sinha, there is one in the YouTube to you. Madam, lipase takes time to reach peak post-pancreatitis. Lipase is specific for pancreas and amylase not, as amylase can be raised in perforation as well. Will lipase help to diagnose pancreatitis on day 1?
Yes, sir. This is what I said, that even the lipase levels go high in post-ERCP pancreatitis. It does take, I do agree, but even the lipase, and in my case, I had seen the lipase had also gone up.
Excellent and very elaborate presentation, Dr. Renuma. Thank you very much. I think young surgeons must learn what you have deliberated, that even perforation can be retroperitoneal and what can be done in that situation. We have dealt with all the aspects of complications of ERCP. I think that will help young surgeons to increase their knowledge and go for it, even if there are complications during ERCP. Thank you.
Thank you very much.
Thank you, ma'am, for such an elaborate description about ERCP. It was very enlightening. So to move on to our next topic, which is by Professor Dr. Subhash Khanna, sir. And sir will be talking about spyglass cholangioscopy techniques and indications. Our esteemed chairpersons are Dr. Sheetal Malwa, sir, and Dr. Sunil Kumar, sir. Dr. Sheetal Malwa, sir, is a professor at Department of General Surgery at RIMS. And I would request Dr. Sunil Kumar, sir, to please introduce our speaker, Professor Dr. Subhash Khanna, sir.
Thanks, Satvir. Dr. Subhash Khanna, a dear friend, a very handsome person, hero from Northeast region, has really taken the Northeastern surgical fraternity to the national, not only to the national level, but to the international level. He has many accolades to his credit. He was the past president of IAGES and also the BC Rai awardee. So with this brief background, I will request my fellow chairperson, Dr. Sheetal Malwa, to speak a few words before Dr. Subhash Khanna starts his lecture. Dr. Malwa was here?
Next, I think sir is not available.
Okay, fine. So Dr. Subhash Khanna is going to speak on cholangioscopy, which is a very advanced technique, and we must listen to him, what he has to say. Dr. Khanna, please.
Thank you, Dr. Sunil Kumar, for that kind introduction, and thank you, chairpersons. Thanks to the Jharkhand State Chapter for inviting me for this presentation. I can see a galaxy of speakers and experts here. Okay, so my job is very simple. The agenda would be what is spyglass cholangioscopy for the very young ones who are attending. And then I'm asked to speak on indications and also the technique of spyglass cholangioscopy. Well, it's very simple definition. When we want to look inside the hepatobiliary pancreatic duct, the CVDs, the choledochus and the pancreatic duct, we use a scope, and that is called a cholangioscope. Now, when we look at the cholangioscopy, we see that what we had been doing since 1968 is we were trying to inject a contrast. That's what we are discussing since morning, into the biliary tree and visualize the biliary tree. Whether we do an MRCP, whether we do an ERCP, whether we do a CT, or whether we do an on-table cholangiogram, our aim is to put some dye and get images. There was some restriction of that, although we had been benefited by this for so many years. But but then there's a lot many problems. We were able to see beautiful stones. We were able to see beautiful strictures, but then we had some issues. The stricture, we never knew whether it is benign or malignant. The stones, some of the stones were hidden inside the hepatic ducts. So we had some issues, and that's why there was some element of failure rate in the standard ERCP. So these were the limitations. The biggest problem was the indeterminate strictures, high incidence of benign pathology in patients undergoing hepatic resection. That means 8 to 25% of the patients who undergo a standard biopsy in a ERCP are likely to go to have a false positive and to undergo major resection without knowing whether it is malignant or not, at the same time without knowing the extent. And that's why we need another instrument. So what we are doing is something like a barium swallow or barium skygram of the upper GIT without doing an endoscopy, looking at an early lesion, or a cholangiography or barium enema without looking into the lesion and getting an early diagnosis when it is still at the mucosal and the submucosal level. So as I said, these were the images. Now we want to look inside. And the only way we can look inside is a cholangioscopy, which can be a single operator, we can be a dual operator, or which we can do directly inside the condylar duct with a thin cholangioscope without using a duodenoscope. The historical barriers we had been trying to do since 1950s, but what we are trying to do is we were used to take a mother scope through which we wanted to pass a small thin baby scope. We needed 2 operators, 2 steering capability. There was no irrigation channel separate for it. That's why unless and until you irrigate and distend or flush out the debris in the CBD, you were not able to see. The scope was very fragile and there was a very high repair cost. The scope cost you 6 to 7 lakhs. And you know, the ureteroscope, the moment the flexi ureteroscope breaks, we have to spend 3.5 to 4 lakhs for repair. Then there were lack of tools for therapy. There were no basket, no biopsy forceps. And we had a limited access to this technology with very poor service. The advantages were, yes, you could do a narrowband imaging or image enhancement. You could take a tissue biopsy, but the image quality was very, very, very poor. Lithotripsy, what you can do in spirocholangioscopy, you could also do in mother-baby scopy. Disadvantages, as I have already mentioned, it was very fragile and it required a wide sphincterotomy because of the diameter. And then came the SPY system in 2007. Initially, we start to have a standard definition, and then we have now moved on to a digital DS system or DS2 system, which is a single operator system. That's the SPY scope, which you can always fix to the side of the duodenoscope, or you can also ask your assistant to hold it. It has 4-way steering, both up and down and right to left movement. It has an independent irrigation channel. That's the SPY scope, which is it goes easily because the outer diameter is just about 3 French or 10.3, 10.4 or 10.5 millimeter. It can use 10 French or 3.3 to 0.3 to 3.4 millimeters, which can easily go into any instrument channel, which is usually to the extent 3.6 to 4.2 millimeter in any of the duodenoscope. And it has an irrigation channel, as I said, and it also has an accessory channel through which you can always take either a biopsy forceps or any other ablation instrument, or you can also take a laser through it. The components are the digital controller, the biopsy forceps, the retrieval basket, the retrieval snare, and the access and delivery catheter. And That's how we introduce the cholangioscope. And you can see I have already put a guide wire in the laser fiber in the cholangioscope here, which is already loaded. I'm just coming to that. So the specifications are, the length is approximately 214 centimeter. The outer diameter is 10.8 French or 3.6 millimeter. And these are the components. We have one video imaging sensor here. We have two illumination elements, irrigation. We have the irrigation channels, and we have working channel both for aspiration and for whatever accessory you want to take inside. This SpyBite forceps has a diameter of 1.2 millimeter because that is the only diameter which the instrument or accessory channel of the SpyScope will take. And once that bite is open, its diameter is about 4.1 millimeter, that we have to keep it in mind. The baskets are very tiny. They're not for large stones. These are only for small stones which are stuck to the wall or which are left later. Sometimes they use the basket for retrieval of a forgotten migrated stand. This is what we are getting, a sensitivity of 30 to 40% in breast cytology, what we used to do with ERCP. And also with a fluoro-guided biopsy, if you want to take, we used to get a sensitivity of 37 to 65%. This is an overall literature evidence. And from there, we want to bring it to about 90%. And that is only possible when you look inside look inside and look at the lesion and take a biopsy with the help of a SpyBite. These are the different images which we see in ERCP. And this is what it looks inside. A very benign looking structure might be having multiple papillomatous lesions inside, that may look inside with a cholangioscope. And this is what I'm hinting at. SpyScopy is easier to perform. You can beautiful images now with the digital system. You can take a large biopsy and you can always have a better suction and irrigation. I think I will take you to what I think we have already spoken about. What are the components, the card, the SpyScope, the fiber, the laser fiber, the biopsy forceps, and the light source, the camera, the component card, and the irrigation pump. Let me take you to a technique, if possible, if the time permits. If the audio is not good, do let me know so that I can speak on the audio and mute it. Talking about the indications, for me, the indications are all difficult CVD calculi. Smaller, tiny calculi in the hepatic ducts can be taken out easily, can be visualized also. Difficult CVD calculus means any calculus larger than 1.5 centimeter, which can be pulverized or we can be broken into multiple fragments and can be taken out. Indeterminate biliary strictures, intraductal papillary mucinous neutroplasm, particularly of the pancreas, pancreatic duct calculi, strictures, and pathology. Even today, I can, with my laser, I can open up the strictures in the pancreas and the biliary tract. Pancreatic stones, primary sclerosing cholangitis is a very, very strong indication. We do not know in which case the patient is likely to has by now developed malignancy. So for a surveillance, we can always use cholangioscopy in these patients. Undiagnosed pancreatitis, selective guide wire placement, particularly in those patients where we fail in putting a guide wire and stand in those patients with obstructive jaundice. A cause of hemophilia, there's a beautiful article where there's a primary early lesion in the hepatic duct, where there is no definite cause of hemophilia known. And another article mentioning about angiodysplasia of the bile duct presenting as hemophilia, which was only diagnosed by cholangioscopy. And you can also diagnose early hemophilia, early gallbladder cancer by that may be a cause of hemophilia in some of these cases. One more indication for me is lithotripsy of the cystic duct stump calculi, which I had presented last year in SAGES also. You can easily dilate the cystic duct stump for any left out calculi, and you can always take it out. For large calculi in Mirige's syndrome is coming up as in a big way, another indication where in the Mirige's syndrome, where half of the calculus or the calculus is seen in the common bile duct can always be broken, pulverized, and lithotripsy can be done. This is the very rough animated view of what we will be doing in this thing. I think rather than animated, we might be going to the actual view if time permits. I will try to finish that in about 4 or 5 minutes. The actual unedited video of spyscopy being done. This is the direct visualization of the common bile duct and the hepatic ducts, and you can see how the normal ducts and the normal hepatic duct confluence can be seen here. We can also have a look in this video of how a polypoid lesion looks like. And you can see a tiny lesion here, which are the cause of hemophilia in such cases. This is just impossible to diagnose in preoperative MRCP on CT scan many a times. I won't say always. And here a large calculus is being seen and broken with the help of a laser, holmium laser, and you can see the stone being pulverized with the help of a laser finder. I'll just come to the biopsy, the spy bite biopsy forceps, which is supposed to be single use, and in fact it is a single use, and you can always go in and take a tiny biopsy and you can get a very good chunk. As I said, the opening diameter may be to the extent of 4.1 millimeter. We have removed worms which have migrated up with the help of spyscope, and I can share that with you here. Mr. Chairperson, please let me know if I exceed time. I will just run a small video.
No, please do. It's very interesting, Subhash. Please go on.
All right. I wish I can show the round worm here. And okay. That's the worm inside the common bile duct, which can be seen very nicely with a spyscope. This is one of our cases only. We keep getting many ascariasis in the biliary tract. Migrative persistent I'm avoiding because I would like to take you to this. This is a new indication where both the pancreatic duct strictures and bile duct strictures can be ablated with the help of a laser fiber taken through a spyscope. Very unedited video wherever I feel that I'm showing time. I hope that I'm audible here in the video.
Very difficult case. You can see in what position I have done a colonoscopy. And can we have a little contrast, Dr. Chaudhary? No. Okay. All right. You can see the guide wire now is in position. The guide wire just enlarge it. Now we will do a balloon synchroplasty. We have done earlier also in this case, but for the sake of demonstration to you, I'll do a balloon synchroplasty. I'm using a CRE balloon, and this is this balloon we are using. This shows this balloon here. Yeah, here. So this balloon is from Boston and has a diameter of 15, where we use a pressure of 8 atmospheric pressure of 3 if we use the gun. Okay, now all the come back to screen. It will be slightly difficult, very difficult once and why the patient may be taking a sample. But it has already this patient already had a balloon synchroplasty done. Audio. Okay, now the balloon will go in. So as we discussed about the balloon, it can be maximum half inside. In this patient, we should not have any problem at all in passing the balloon. And so here, on the spyglass case, very difficult case. You can see the fluoro. contrast so that you can see the balloon there in the fluoro. But the moment you start studying it with contrast, we will not be able to this long. So we are waiting. Here the camera is showing 1 minute is gone now. So I will be most of the gastroenterologists and the endosurgeons will study, keep it distended for hemostasis and for a proper stretching, a proper sphincteroplasty for a minute. We usually follow 2 minutes. So we get almost a perfect hemostasis in such cases, but doing a balloon sphincteroplasty before introducing my spy camera. You can say the perfect hemostasis in this patient, our balloon sphincteroplasty, because we have inflated the balloon and kept it inflated for almost 2 minutes. Presentation, I must have shown you. Now we are taking this the spy camera here, the DS2, and that's the spy scoop. And the tip I'll be showing you in the presentation. I must have shown you the irrigation one. We'll be taking the laser fiber here. That's the irrigation pump which we use routinely. Apart from that, you can also keep a chamber syringe ready for irrigation. So just show the close-up of the fermium laser. There's a voltage laser, 30 watt, which we are going to use now. And now, before I go in, because once we are inside, we are taking the laser fiber, 200 microns inside, because more than 200, we have 400, we have 600 that will not go in the thin axillary channel of these accessories there. Now you can see the laser fiber has come. We'll just see the two screens are there. One is the spy screen and the other is my endoscopic image coming. So now adjust it because it's very difficult angle, and we can see the inside of the CBD right now. You can see both the screens. Also to all, and now you can see the scalpelus here. Can you? I hope you can appreciate. You can see. So we'll just position ourselves. We can see the.
I think you can appreciate the large calculus there. I might have to run it fast. It's totally unable to see. Here it's being fragmented. I'll just show the laser fiber.
Okay, you can see the laser being pulverized in the calculus. Trying to break as many fragments as possible. And almost in the last part. Also, so like with the basket, open the basket once. With the root and more many fragments there.
Okay, I think this video itself summarizes, and the indication summarizes what I wanted to say. The benefits, we can evaluate the strictures very nicely. We can reach the hepatic ducts, we can reach the tiny pancreatic ducts, we can always dilate and always go in. We can evaluate the hematuria. We can have a visual guided laser lithotripsy. We can put a guide, and we can also go for a ablation of ductal tumors. We can also avoid transplant in multiple papillomatosis in the biliary tract. Ladies and gentlemen, this is one method of treatment of intraductal lesions and very, very difficult cases of hepatobiliary tract. New algorithm and guidelines will be made and rewritten. Let's have a new technology to the benefit of mankind. Thank you very much. Thank you. I'm sorry for exceeding time a little bit. Thanks.
Subhas, it was very interesting. So we have something to learn. One little question from my side. Suppose someone is trained in ERCP and then Is it difficult to, do your spy glass and, or is it little require more training or cholangioscopy?
Thank you, Dr. Sunil Kumar. Not at all, not at all. It is something like an accessory being taken inside through the working channel or instrument channel of a duodenoscope. There are little bit one or two small tricks. As I said, the laser needs to be loaded. So one laser cost is there, and laser we all have. We do a lot of urological work. URS, RIRS cannot done with a laser. The same holmium laser you'll be using here. The fiber needs to be loaded, because once we are inside in that angulated cholangioscope, the laser fiber doesn't go in. So you don't need a special training at all for laser literacy. There is hardly any complication. The complications are similar to what Dr. Arunima Verma had just now said. Same complications of pancreatitis with less chance of bleeding, because we normally avoid doing a sphincterotomy. If one doesn't want, he can also go inside with a spy scope even without doing any sphincterotomy or sphincteroplasty.
Right. And how many cases of this cholangioscopy would you do in a month on an average?
I do about 8 or 10 in a month. About.
That's not bad. So there is a question, Subhas, I think you can answer. There is someone called Srinivas B. Kulkarni. Dear teachers, as budding surgeons, many of us are willing to learn ERCP.
Yeah.
Kindly suggest a short-term training course and mentor us. Congratulations, ASI Jharkhand chapter, for such wonderful CME. So can you speak 2-3 lines so that the budding surgeons...
Hi, very nice question. This is on behalf of ASI and IAGS. Or IAGS runs dedicated, on ASI runs dedicated endoscopy and advanced endoscopy courses. We in Guwahati are running dedicated ERCP course. The first course is going to be over next month. Now, what we do, you can either select a center of your choice and go for a fellowship there for 6 months to 1 year. If you are not if you're a very busy surgeon, then you join one of our online courses. 3 months you are on with us for all the didactic sessions, the way you have attended almost all the sessions, starting from basics of an endoscope to cleaning of an endoscope to disinfection to a duodenoscope and doing a basic duodenoscopy, and finally you are taking to ERCP in difficult situations. So all the didactic sessions are over in 3 to 4 months time, followed by hands-on. The day these 24 doctors are right now undergoing training, they will come to us. That day we are going to keep 24 cases for them, and each one will be doing ERCP on his own, and thereafter they will be mentored in their own centers. And that's the procedure followed by ASI, IAGS, and we in Guwahati. We are running dedicated ERCP center, ERCP training course. The first course will be over, and thereafter we'll be announcing the second course. I'll be in touch with you all.
Thank you, Subhas, for a wonderful lecture. Back to Arunima and Satvir. Thank you very much, Subhas. It's wonderful. Thank you.
There's a question that what is the effect of previous lap pulley on ERCP? I think that question was directed to me. I said pre-lap pulley. So what I meant by pre-lap pulley was that, there are times when we take up both the cases together, that we do a ERCP followed by a lap pulley. So that's not a very good thing, because, the whole bowel is distended and you find doing a lap pulley very difficult at that situation. And obviously, if you have had a previous laparoscopic cholecystectomy, I think as in any other endoscopic procedure, because of adhesions and all, at times intubation and all can be difficult, because your duodenum and all that can have adhesions. But if any other faculty wants to add on this, it's welcome.
No, that's point. Yeah.
In case you want to do both the procedures at the same time, do lap pulley first, and then if you want to be very, very safe, put a guide wire in the common bile duct so that you don't fail in ERCP. So you need a hybrid OT. So do a lap pulley first, and thereafter do a ERCP on the same sitting, on the same table. Patient is taken, either they bring the side wing scopy there, or take the patient to the endoscopy suite, because what we practice nowadays is the operation tables are similar. So you can always drag the operation table to the endoscopy suite also. So same sitting, it can be done. Post ERCP lap pulley is always difficult. Do it in 48 hours. 24 hours, wait, because the patient may have pancreatitis. So that next day morning, you are going to do a amylase, lipase check whether the patient has pancreatitis. You're not going to do, but after 48 hours, you can always do if you are very confident about your ERCP. That's what we follow, and that's what almost a standard guideline. Sorry, Arunima, I just added to what you said.
No, sir. Actually, I asked you to add. I asked or anyone to add. Anyway, thank you very much.
Yeah.
I think we'll move on to our next session. Satvir, you take over, please.
Thank you very much, sir, for enlightening us on spyglass cholangioscopy. And we move on to our next lecture, which is ABC of colonoscopy for surgeons by Dr. S. Ishwaran Murthy, sir. And our esteemed chairperson is Dr. Pankaj Bodra, sir. Sir is a professor at Department of General Surgery at RIMS, and he has been an examiner to various MS and DNB specialties. And I request Dr. Pankaj Bodra, sir, to please welcome Dr. Ishwaran Murthy, sir. Dr. Pankaj Bodra, sir.
Good afternoon, everybody, all those who are present today. And I'm very privileged to have Dr. Ishwaran Murthy with us today. And he's Honorary Secretary, IIGS, and actually Department of Minor Access Surgery, Lotus Hospital, Erode, Tamil Nadu. And his qualifications not there. And he's having special interest in therapeutic endoscopy and neuroscience. So yes, Mr. Murthy, you proceed with the resolution. Thank you.
Thank you, Dr. Pankaj. Thank you, Satvir.
Thank you, sir.
Thank you, Dr. Sunil Kumar, Arunima, and the team, ASI Jharkhand. I think you have done a commendable job trying to inculcate the knowledge of art and science of endoscopy, colonoscopy, ERCP to all the budding surgeons across the country. I think as an IAGS Honorary Secretary and also the ASI past chairman, Tamil Nadu chapter, I bring greetings. Let me go to the chapter without wasting much time. If you allow me to share the screen, let me just see.
Friends, ladies and gentlemen, thank you for your invitation. Today, for the next 15 minutes, I am going to share with you the top 10 tips and tricks of colonoscopy for you. Because we all know doing a good colonoscopy is a very challenging task. Because we have very high quality indicators for a good colonoscopy. You should reach the cecum almost 95% of the time, and we should not miss even a single polyp. Our polyp detection or adenoma detection rate should be around 25% in a men more than 50 years, and there should be no complication, major complication like perforation. So to achieve all these things, we all need a structured training program. I'll share with you, after 20 years of this practice of colonoscopy, art and science, top 10 tips. Here they come. The first one I would say is to go for something like this, a high definition colonoscopy. It is like driving a Mercedes, be it an Olympus, Pendex, Fujinon, doesn't matter, because high definition endoscopy, because of its image enhancement technology and also magnification, it is able to give you very crystal clear pictures with a diagnosis which you can make even without doing a biopsy. In other words, you are making an optical diagnosis without an in vivo biopsy. So this is a great advancement of the image enhancement technique. The second, of course, for every colonoscopy, you need to have a good bowel preparation. We do a simple ritual of bringing the patient with a low residue diet for 2 days and give them 2 liters of this polyethylene glycol. If you give it over 2 hours, they clear the bowel. There are some adjustments you need to make according to some other specific conditions like a chronic constipation or inflammatory bowel disease, but in our experience, this single good bowel preparation makes all the difference because you are already halfway to success. When you see the colon, after this good bowel preparation, you have to assess how good the preparation is. Is it excellent? This is what you want to achieve. That is score of 3, the Boston bowel preparation score. Next, of course, is a setting up. You need to have something like a cockpit drill, how you want to have the patient laid with a vent flan, and also you should have a nasal oxygen, and you have 2 assistants on either side and their role, and also you need to have a clear patient checklist and equipment checklist like a pilot before starting the plane what he does, because we should know clearly why we are doing in this case. I have enumerated various indications. One of the common indication, of course, is a rectal bleeding and a diarrhea, but there are other conditions where it may be required like a screening and surveillance. Of course, we should know when not to do a colonoscopy. For example, when you are suspecting any acute abdominal or perforated viscous, or even an acute diverticulitis is a relative contraindication for a colonoscopy. And once we know a good history, patient's comorbidity, previous surgery, get an informed consent, then get the patient on the table. And this is the cocktail we normally give. A combination of midazolam, tramadol, buscopan in our hand is quite good. I'm sure you can try pethidine or a ketamine or a propofol infusion also is quite welcome. And lately we use routine use of the carbon dioxide insufflation, and that made all the difference as far as the pain threshold is concerned. But we need to be very vigilant whenever we do any such procedure. So we need to monitor the patient, and we need to teach our staffs also the importance of the safety during the procedure. Coming to the next thing, I'm sure some of the cases beyond diagnostic, you may see a polyp that need removal. For that, are we ready with our team with the tools? That's also important, and I'm sure you should know the technique of polypectomy, and you should have the right temperament to do, because some procedures like ESD may take sometimes several minutes to do, so you need to persevere and perfect this art. And I would say these 3 things are a great addition for every colonoscopy unit. A good irrigation pump to clean the bowel if it is not completely ready, and also, as I said earlier, carbon dioxide insufflator and a good thermate having the property of the endocut modality. Let me just start with you today being a brief talk in the 5 important golden rules of colonoscopy. The first important thing, of course, is you need to learn to be what I call an ambidextrity. You see the picture, it is what I call an one man. So you with your non-dominant hand, you hold the control, and with the other right hand, you just torque the scope, because the right hand torque steering is a success for navigation. So you should learn this particular art in order to do a good seamless colonoscopy. And once you go beyond rectum into the sigmoid, as you can see, you just to follow the darkness wherever there is no light. For example, the first picture around 10 o'clock, the second picture at 6 o'clock, and the third picture, as you can see here, where this Taenia coli is taking you, because that gives you a direction. The lumen is around 12 o'clock. So you need to bring the big wheel towards you. So whenever we bring the big wheel towards you, you are looking up. And whenever you are taking the small wheel away from you, then you turn the right. So all these wheel movements, talking sat movement, and to some extent your body movement will make a good navigation. Because as far as the sigmoid is concerned, as you can see, by nature it goes for this alpha curve. So you need to do what we call the clockwise or right hand torque steering, like this. If you do this torquing, then like a screwdriver, the slowly you ascend, go into the what I call a sigmoid descending colon, and that's where I think you have already done a 50% of your navigation. Then going in the descending is something like going in the motorway. It's fairly a straightforward job. So a good bowel preparation, as you can see, is of success. Sigmoid navigation is a near success. The next, of course, is loop is a possibility in every case. Whenever you push 1 centimeter, but the scope tip is not progressing a centimeter, or every time when you push the scope inside, patient is just having a lot of pain, or there is a stiffness in the control head, or what you call a paradoxical movement. You push the scope, but actually the tip of the scope recedes back. Then you have to suspect one of these 2 loops are happening. For example, here as you can see, this is N loop, and here what I call alpha loop is happening. So what is the reason? Because what was a pelvic colon now trying to be an abdominal colon because of the long sigmoid mesentery, as you can see, an N loop, and that can be easily managed by a technique what we call a pull back. You need to pull back and also keep maintaining the suction, and if you have a stop, they can push the what we call the suprapubically, they can put their hand and then help you so that the colon doesn't ascend in the abdomen. Of course, alpha loop sometimes happens like what is shown in the first picture, and that can be prevented by what I call a right hand torque and also pull back. If you do that, that will also reduce this loop. So this particular pictorial representation with a scope guide, one of the novel device, if you have 190 series, you will be able to see the first picture is going to show you the N loop, the second one is going to demonstrate what I call the alpha loop. N loop is a problem at the sigmoid descending colon junction, whereas in the alpha loop, the scope will go very easily right up to the descending colon and also to the sphenic flexure. Then only you will feel the difference. That time you are already 1 meter. Then what you need to do is you need to go for what I call a right hand torque, then keep pulling and maintain the suction at one fine, as you can see here, it will be reduced, and then that's the way to go. I think scope guide made all the differences, but still I am sure without that also you can master the skill of reducing this. Whenever there is some difficult challenging moments, always there are two things will come to your rescue. One of course is changing the patient position, and second is pressure at the appropriate place. One of the position I would say is the right lateral. For example, here if you see, if you have a difficult sphenic flexure acute, one you can do is ask a patient to take a deep breathing, and you can what I call is the diaphragm comes down, and during that time you will be able to go. If there is any difficulty, you can do something else, that is turn the patient to right lateral. When you do that right lateral position also, that will also help you to navigate this hyperacute sphenic flexure. As I said, the first picture, as you can see, the suprapubic pressure is the most important thing to prevent sigmoid ascending up as far as the abdomen is concerned. If there is what we call a gamma loop because of the long transverse colon, you can go for epigastric pressure. And very important message is message number 6, that is there is no definite signpost as far as the colon, unlike in upper abdomen or endoscopy where you see the greater curvature, lesser curvature. Here you don't know where you are. Are you in the descending colon? Are you in the transverse colon? Because sometimes you say there is a lesion in the transverse colon, but it could be still in the descending colon. So you have to realize this important message. The one definite finding is meeting and greeting the cecum, because cecum is a definite spot because it has 3 characteristics as it's shown here. One of course is the ileocecal valve, and the second is this crowfoot sign, as you can see. Third is appendicular opening. All these things you will be able to see, and especially the ileocecal valve, if you are able to see, is a bivalved lipomatous lesions, and if you are able to see the appendicular opening, and you can just imagine as if an arrow is from there, it is pointing towards the ileocecal fold. Underneath this area is only the ileum, and you will be able to do what I call a ileal intubation. So this is what I call a bow arrow sign. So all these things you also learn, and never forget the point number 8, that is the withdrawal of the colonoscopy is more important than insertion. So you have to be slow and steady, not to miss any lesion hidden behind the fold, and also at the end you have to retroflex so that you are able to do it. Is like a retroflexion for a frontal examination when we do the upper GI endoscopy. So you will be able to see a lesion, and you will be able to see the piles, all these things by this simple maneuver, but may be difficult in a case of inflammatory rectum or a radiated rectum. Coming to the next important thing is, a very important thing is prevent perforation at all costs. That is a very, very important thing. Maybe because of your inexperience, or because you are using excessive force, or because this patient is a high risk patient with the fixed lobes, especially previous hysterectomy, it could happen. See, for example, this particular patient had a previous hysterectomy. We are going in rectosigmoid junction. We are not able to go at one fine minute. See, as you can see, I have to go big well towards you. As you can see, we are already gone beyond. You can see a big hole, because when it's any perforation happens during diagnostic colonoscopy, the hole is quite big. Unlike a condition like a therapeutic one, like an ESD, where the hole is small, you can manage with something like a hemoclip. This is what's shown radiologically. Early recognition, early treatment is vital. Otherwise, patient may have a significant morbidity and even mortality. So that's why I come to the final point. The training is very, very vital. How you train yourself, because nowadays we have the luxury of what I call this plastic model and also this GA mentor. As you can see in this mentor, you can see very nicely, you can demonstrate various types of this loop formation, and you can navigate nicely, and you can go and touch various spots. You can you can ask your residents, spend about 10 hours today before you perform tomorrow. So you can very easily see how he is reaching the transverse colon and how he is entering the ascending colon. All the tricks you can teach it in this mentor several times before you go into the actual patient. So that is the benefit of this today's training program. So ladies and gentlemen, to conclude, colonoscopy, before you venture, try to acquire the best colonoscopy in your hand. There is a high definition colonoscopy is no longer an optional, it is essential in my opinion, and every one of us should undergo a structured colonoscopy training. And I think we need to have the right mindset to perfect the art, and we should have always a good mentor to learn the art. I'm sure if you do that, the patient will enjoy, and it is the practice that makes this art and science of colonoscopy a very enjoyable one, and for benefit of all of us and all of us surgeons. Thank you for the opportunity. Thank you. Jai Hind.
Hello. Thanks a lot, Dr. Ishwarmurthy. Very well explained ABC of colonoscopy. Hello.
Yeah, thank you, Pankaj.
Yeah, sir, and the looping, which we come across very commonly, and how to ignore and how to reduce that looping. It's very important, and I've seen many people doing it, but as you told very beautifully, I'm very happy to know. I'll try my next colonoscopy by your technique. Thanks a lot, sir. Anybody has any questions?
Yeah. Ishwarmurthy has been an excellent trainer, and for the benefit of people, he has given us the complimentary. He has shown it, but this is the book written by him just now. ABC, Arts and Science of Colonoscopy. And so, Pankaj, you can popularize whoever wants to get into it. Train. So I have gone through this book. It's a wonderful book.
Dr. Vijay Kumar, your video is on. Please switch off your video. Dr. Vijay Kumar.
Or Arunima, can you put off the video of Dr. Vijay Kumar, because
he's in OT, I think.
Thank you for your compliments, Sunil. Of those who wanted to get the address where they can acquire the book, please contact either me, or I'm sure Satvir Singh or Sunil can. I'm very happy. He has an endoscopy book that was written 3 years ago. This is a passion. We wanted to teach our surgeons, because the surgeons, I think we all going to work more and more in the flexible platform in the future. Otherwise, like POEM, most of the procedures are made to go out of hand, even for a laparoscopic surgeon, in my opinion. So I think 10 years down the line, it could be a different way we are going to perform procedure. I think we need to train our youngsters. That is our moral obligation, I think, as an association.
Yes, sure.
We share.
Thank you very much. And Dr. Ishwarmurthy, thank you very much for that copy. Definitely, we are already popularizing it, and I think more such books are needed. And I think all your videos on YouTube are also very famous. Because
Arunima, if you don't mind, if you could send me the addresses of HODs of various medical colleges in Jharkhand, I can send them a complimentary copy of few books for each medical college. That I'll do that, so that will be kept, and that is, I'm privileged to do that, because we have assistants from all the companies, so it is not a matter. So once I have the addresses, I'm more than happy.
Sure. What else suggest? Not HOD people who have shown interest, like we have Professor of Surgery Pankaj Bodra, we have Professor Sital Malwa, so we should send to them who have shown interest. So we will
Definitely, sir.
send a list of people, 5-6 Arunima can send. You
We'll
just go
send that, sir.
and send. And I know,
We'll
thank you
send
very
that
much.
with
You
the
have already
address.
sent me to complimentary for the trainees. So I have two complimentary copy which I'll give to. I thought I'll give it to Arunima, but I never realized she has become a faculty. I got a complimentary.
No, sir, I'm still your trainee. I'm still your
Yeah,
trainee. So you
that's
can
all.
share that with me.
But we will send me to Pankaj also and Sital.
Thank you.
Pankaj,
Thank
you
you.
do colonoscopy in RIMS?
Yeah, we are doing it, sir.
Oh, that's great. Yeah.
Upper, lower, both. Yeah, we have ERCP also.
Okay. Oh, very nice. Very nice. Chalo.
Thank you very much, Dr. Iswar Murthy, and
Nice
we
interacting.
learn more from you.
Yeah. Thank you, Arnima.
Thanks a lot.
Yes, Sadhvir.
Thank you, sir. You every time I watch your video, I feel elated to do much more colonoscopies. Thank you, sir.
Thank you, Satya.
To move on to our next lecture, which is by Dr. Satish Midha sir, and sir will be talking about monitoring and drugs during colonoscopy. And our esteemed chairperson is none other than Dr. P.P. Chawla sir. And Dr. P.P. Chawla sir is a director of medical sciences at Tin Plate Hospital, Jamshedpur. And I welcome Dr. P.P. Chawla sir, and I request to please welcome Dr. Satish Midha sir.
Hello. I have very great pleasure in introducing Dr. Satish Midha, a very good friend, and he is a versatile and excellent speaker from this part of the country. And he is a consultant laparoscopic gastrointestinal surgeon and therapeutic gastrointestinal endoscopist. He has held various posts in various associations and subsections and has always run the sections so well. He is going to speak on a very important subject of monitoring and drugs during colonoscopy, which is really very important for all this what we have heard so far. Ladies and gentlemen, I have great pleasure in presenting Dr. Satish Midha, the versatile speaker from the Eastern region, Ranchi.
Thank you.
Dr. Midha, please.
Thank you very much, Professor Chawla. Respected Chawla, Dr. Sunil, Dr. Arunima, and the whole organizing team, my co-faculty members. Can you allow me to share the screen?
Yes, sir, you can
please go ahead.
Can you see my screen?
No, sir, it's not yet visible.
Anand, can you please look at the technical details?
Anand?
Anand, are you there?
Sir, are you unable to share your screen, sir? Are you getting the option of share screen?
I am getting the option.
So just click on that. So just the green thing lower down.
It's saying open system preferences.
Yes, sir. You need to give permission, sir. If you are sharing first time, you need to give permission there in system. Are you using Mac, sir? MacBook?
Yeah.
Yeah, you have to give permission.
Anand is here, so not possible with the Mac.
It is possible, sir. Only thing they have to approve.
So in system preferences, what does he have to do, Anand? Can you just
He
guide
has
him?
to accept share screening. Accept you have to do, sir. Accept.
Carlo. So
You have to select the Zoom icon. You can see the Zoom icon, sir. What options are coming, sir? There, any options are you are able to see that?
I've got basic, advanced, and files.
You cancel the access, please. Cancel the access. Come back to Zoom. Click on share screen.
Now I'm clicking on share screen.
Okay, sir.
There are three options: basic, advanced, and files.
Okay. The advanced you click.
Anand, you can't say from at your end. Oh no, yeah, the presentation is not there, no?
Yeah, yeah.
Okay, I'll try from another computer.
No,
Just
sir, you select advanced and say okay.
So
then
can we move in the meantime? Satish, can you sort it out? Can we move on in the meantime to the next speaker? You sort it out?
Yes.
Satvir, we have.
Can you just sort it out separately with Dr. Satish? Okay,
Yes,
we'll go on to the next presentation and we come back on this presentation after that is sorted.
But the next speaker is there.
Yes, so we are already a little behind
It's
schedule.
okay.
Yeah. So Dr. De Sarkar is already there, sir. I can see.
So move on to the next speaker is on colonoscopic pathology by Satyapreet De Sarkar sir, and our esteemed chief guest, esteemed chairperson is Dr. Mohammad Azad sir. And I would like to invite Dr. Satyapreet De Sarkar sir, and sir is the honorary treasury of IIGS 2021. He is an HOD gastroenterology of GDDI Hospital, Calcutta. Sir is an excellent teacher, academician, and convener to multiple hands-on training programs for endoscopy, and sir has number of publications. And sir has been recently awarded the most hardworking doctor in 2021. That I got it from his Facebook post, sir. I request Dr. Azad to please welcome Dr. Satyapriya, sir.
Once again, my screen showing you cannot start the screen while the other participant is sharing.
Now you can do that, sir.
No, it's still there. I think he has to allow from the central host. He has to allow me.
Anand, please allow sir to screen.
Allowed.
Anand, please allow me. It's written.
Allowed, sir. Just try 1 second, sir. Try now, sir.
Can you see?
Yes, sir. Yes, sir.
Okay. Now you can have my introduction.
Good afternoon, sir. Welcome, Dr. Satya.
Yeah, Ajad, you are there. Please tell. Huh?
Yeah. Welcome, Dr. Satya. As we are running short of time, please start with your presentation.
Yes. Thank you. Only 2 points are there, Shadbir. At present, I am the chairman of National Endoscopy Board of IAGS, and I am the first one who got the international honorary membership of American College of Gastroenterology as surgeon. So these are the important things. And also I have started the EndoSARC-Con, where the people from all the SARC countries from Herat to Myanmar, they have registered. And every week, 7 to 8, every Saturday, one class is going on where I am the course director. So I felt that these are some of my dreams came true. And with these points, I really feel proud, privilege to talk after my very dear friend, Ishar Murthy, whom I consider as one of the best teachers in India about endoscopy. And me, Ishar, Govindraj, our Satish Midha, Sunil Popat, all of we are contemporary, and we are trying hard to go with our small knowledge and sharing with the delegates. So that's one. GI endoscopy is a non-surgical procedure used to examine the person's gastrointestinal tract using the endoscope, a flexible tube with a light and camera attached to it. Now, important thing is first you should know the normal colon. So if you know, you can only diagnose the pathologies when you know what is normal, and then only you can know what is abnormal. So that's a very important point. That's the whole colonic anatomy, the Taenia coli, plica semilunaris, hostile folds, why there, the small thing. That's the anal canal. The forward view may not allow good visualization due to anal sphincter contraction. So at 20 centimeter after introduction, 20 to 25, 2 centimeter, you can make a retroflexion, which can show the dentate line junction of the pale anal squamous epithelium and the pinkish red rectal columnar mucosa. The rectum, I see clearly visible submucosal veins, typically visualize rectal mucosal vascular pattern and the crescent-shaped rectal valves. These are 3 valves are there. These are very important because it is very important to diagnose in which part of the colon you are there from intraluminal part. You do not have a fluoroscope usually. You do not have the magnetic field things like the Japanese. So you cannot, you have to clinically judge whether you are making loops. You have to clinically judge by vision which part of the colon you are there. That's the sigmoid colon. Coming to that, the oval haustral folds, prominent tinea at the convex curve, curving sharp, difficult to view through inside the curve. Then coming the descending colon, where is the relatively straight path, much more oval lumen and evenly spread haustra. So that part going through is a better one. By the side, I am again showing where is our scope and what we can see. Now, after passing through difficult splenic flexure, that's we can see as a shiny angle, and the splenic impression most of the time you can see as the blue hue which is there. After passing the splenic flexure, going to the transverse colon, a triangular configuration, evenly spread haustration, and this is the easiest part. Actually, we travel very smoothly. You can see the position of our imaginary colonoscope. After covering up the transverse colon, you go to the shimmering bluish coloration of the liver and caudally angulated lumen, which is the hepatic flexure. After hepatic flexure, you are very close to your target. You are in the ascending colon, relatively wide, triangular shaped lumen, and the IC valve protrudes in the lumen and the thick yellowish fold. And then coming to our main point, the cecum, how you can make it tinea more prominent, gives you a Y-shaped or crow foot-shaped appearance due to the confluence of teneas, appendicular valve visualized, IC valve seen more frequently during the retroversion. And you can see again the position of my scope. And the ileocecal valve is not always very conducive. That sometimes it looks at you, you can go and have a beautiful ileoscopy. Sometimes you have to go down, make an upturn, and then slowly motivate with the fine tuning, you go into the ileum and make your ileal pathology diagnosis. So that in one place, the places where you can see, and the beginners should know where you are, whatever you are doing. If you're getting a lesion, you have to describe it relation to the anatomy. Now coming to the common pathological findings of the colonoscopy. I'm not going into details. Diverticulosis is not that common as they get in the Western literature and Western world. The diverticulosis, diverticular bleeding, diverticular perforations are very common, but we rarely get it. It's due to, with it maybe only diverticulosis without an inflammatory change, and mucosal thickened folds are there, and occasionally pseudodiverticulum at the vascular proximity and may contain the impacted fecal matter. Many of the time you see how fecal matter is inside the diverticulum staying there. And when diverticulosis goes into diverticulitis, when there is edematous folds, mucosa congested with the patchy reddened area, vascular pattern partly obscured but still discernible, ulceration may be present, stenosis and stricture of the lumen in advanced cases of diverticulitis. Then coming the most important and glamorous thing of polyp, which we have started with Mr. President Sunil. It can be stalked polyp, it can be pedunculated polyp, it can be sessile polyp, it can be flat polyp. But for all these things, first you have to diagnose, take biopsy, then do the paths which are shown by Sunil and go for taking it out, as this should not be kept there and watching silently. Now turning maybe many of the polyps you have not detected in time, and from there is turning into the malignant tumor. It may be de novo also. There can be ulcerative type, it can be growth type, it can be flat migratory tubule, or it can be smooth elevation. I use my NBI for last 5 years, and I have also presented in Greece 500 cases of my experience of NBI in Eastern India and their national university. And I really feel NBI is a fantastic modality where you can have an idea about what is the pathology of this thing, these growths. The submucosal tumors are very, very important. You should understand and differentiate between the polyps and the submucosal tumor. You can make out the mucosa moves nicely over the tumor. A smooth, maybe ischemic places very rarely, but otherwise very smooth, because I have seen twice the learners have tried to, mistaking as a polyp, tried to take it out, resulting in the colonic perforation. So be careful. Leiomyoma is much more smoother, bigger, but again a submucosal thing. It can be carcinoid tumor. I'm not going into that details. There are non-epithelial tumor, malignant tumor, so many submucosal tumors can be, and you can, many of them you can at least make out that these are the submucosal tumor. Then CECT can help you out what's going on. And colitis is very important. The edema, erythema, erosion, ulcer, necrosis, stricture, and scarring. See all the different types of complications of the colitis. Should train your eyes, then only you can make out which is scope-induced frictional injury and which are the colitis and what are their complications going on and on. And really, you can have a nice diagnosis if you are little habituated with that. Then coming to the inflamed granular mucosa, this ulcerative colitis or IBD, commonest thing. Remember it, most of the cases starts from the rectum and goes in a continuous manner, and it has a normal vascular pattern loss in chronic cases, and linear, longitudinal, continuous ulcer can be, there can be pseudopolyp, there can be exudation, there can be bleeding, there can be contact oozing. All these things depending on how severe it is, whether acute or chronic. Always you should take enough biopsies to come out. Crohn's disease, theoretically very easy. Sometimes you have a beautiful skip area, you can make out the typical punched out lesion, the typical cobblestone appearance, left side down, you can see that one. And deep ulcers can be there, strictures can be there. The most important of differentiating Crohn's disease is with the tuberculosis. But if you see your eyes, definitely there are a few points endoscopically you can make out which is Crohn's, which is tuberculosis. Take adequate biopsies, number of biopsies from the right place and go for that one. IBD, sometimes you cannot make out whether ulcerative colitis or other indeterminate colitis, whether Crohn's colitis from your endoscopic picture, even after doing more than 1 lakh endoscopies like me. Then coming for the ischemic colitis, very uncommon now, but it's a very deadly thing. And for the older patients, sometimes with bleeding and other, the patient comes, you can have this sort of ischemic mucosa, the reddish blood-soaked mucosa, increased mucosal fragility, submucosal hemorrhage, necrosis, and fibrin deposition. And these are the points, again, you must be printed in your brain, otherwise you will miss it. You cannot diagnose at time. Then some acute GI bleeding, maybe from ulcer, maybe from polyp, maybe from vascular dysplasia, hemorrhoids, maybe from malignancy, mechanical injury, even radiation injury. Now we have so many things. We have clips, we have APCs, we have injection of adrenaline, even we have the Obesco's clip. So we can, many of the places, at least temporarily for a proper resuscitation, we can almost always control the acute GI bleedings with our endoscope. Rectal ulcer is a huge thing. I'm not going into the details of that. The chronic solitary ulcer, there can be radiation ulcer, Crohn's ulcer, rectal CA, lymphoma, NSAID ulcer, ischemic colitis, starcoral ulcer, prior polypectomy after that ulcer, inguinal lymphogranuloma, very uncommon now, syphilis, gonorrhea, herpes, chancroid ulcer, all can be seen in the rectum and should always keep in your mind. You do not know. The rare thing comes rarely, and you can only diagnose if you don't forget it and keep it in your mind that it always can be. And some very infrequent findings I'm including. There's an endless thing, but still the important infrequent thing is pseudomembranous colitis. Fortunately or unfortunately, last 2 months, our unit has diagnosed 2 of these pseudomembranous colitis. Both the cases, patients used to be very sick and had a long history of taking one after another the antibiotics, and initial plaque formation, reddish halo mimicking underlying inflammation. The confluence of plaques happened. The eolish plaque when tending to chronicity, and confluent eolish plaques after washing. If you take the biopsy from the place, send the Clostridium difficile toxin antibody also, and diagnose the case, give vancomycin and other, treat it properly so that you can really save the life. Vascular malformation and other lesions like angiodysplasia, hemangioma, vascular ectasia, sometimes they are the cause of bleeding and intermittent bleeding. So again, you should be very cautious at every point. At Isharmurthy was telling you, go look it very delicately and with all your passion so that you don't cross it without looking into that. Melanosis coli, again, a very uncommon thing, dark pigmented mucosa from light brown to black, sometimes a leopard skin-like appearance, in advanced cases, dilated colon with loss of hostra, and often tiny polyps and inflammatory mucosa usually happens when the irregular and irrelevant and illogical use of the purgative self-prescription for decades together, and you lead to this very bad situation. Ultimately colostomy, and you can go into the ileum also. I think the list can be endless, many more, but these are the very common things. If you remember these things, in 99% of cases, you can jolly well go into that. Please keep it in your mind, see it repeatedly, go through the Atlas book by Ishar. These are fantastically described and you can make out. Thanks all. Especially I forgot to thank Sunil, Arunima, Shadbir, the trio who previously also gave me a chance for my passion of teaching and sharing my experience with my surgical colleagues, where I'm really dedicated my life of teaching endoscopy. Thank you. Thanks everybody.
Thank you so much, sir.
No, Azad, you are muted. Azad is muted. Azad is speaking. Azad, you are muted.
I think centrally he can be unmuted.
No, I know. But Azad, you are
Hello.
still muted. Azad, you are still muted.
Can you hear me?
No, Satish, just a second. Azad, you are still muted. Just give a concluding remark.
Azad sir, I have sent a permission to unmute yourself.
अरे आजाद को फोन करके बोलो ना, उसको म्यूट से आजाद करो।
म्यूट से आजाद करो, लेकिन दाढ़ी बढ़ाए हुए बड़ा हैंडसम लग रहा है। आनंद, तुम ही
अनम्यूट you please unmute, make him unmute.
Sir, I am sending him request. Sir, please accept my request.
Azad, accept.
Azad,
yes, fine.
Hello,
He's not unmuted.
Hello.
Azad, yes, all yours.
Yeah. Yes. Excellent presentation, sir. Dr. Satya, you made us feel that we were sitting in our lecture theater in 1980s. I think all those who are present on this virtual platform have benefited very much by your lecture, sir. Thank you very much again on behalf of ASI Jharkhand chapter, sir.
Thank you. Thank you.
We can move on to our next speaker, sir.
Yeah, Satvir, back to Satvir, yeah.
Yes, sir. Thank you, sir.
I think Dr. Midha has sorted out his issue. So can we have Dr. Midha's presentation?
Of course.
Yes.
So we invite Dr. Chawla. He has introduced Midha, and please request Midha to share his screen and start talking.
Sir, Chawla sir had a important work too, so
Okay, that's all right. So he has been introduced. So Midha can start directly now. Midha, Satish, you start your talk. Share or whatever. Satish is there.
Sir, in the meantime, Dr. De Sarkar can answer a question that is it's not a question directly related to your presentation, sir. But since you are a very senior person in this field, so you can answer this. That if given a choice, is it better to have hybrid or a separate setups of operation theatre and endoscopy theatre?
I always feel it should be a hybrid one. It's a big struggle. G.V. Rao, my good friend, told me that you feel always very successful if you can put your endoscope in the OT. Everybody will stop it, but you do it. I did it. I feel hybrid is the right thing, because anytime, sometimes you do not know when you need it. During operation also, part operative endoscopy, is one of the thing. So if you are allowed by your management, always make a hybrid OT with that.
I would just add to it, I have worked in both situations. Right now, presently, I work, all my endoscopies are done in the OT, and I think I agree with you completely, sir. It's a blessing. Usually what happens is that OT time is so precious that endoscopy is not given the OT slots. But having that is, I think, a luxury. So I think if we have that, we should have it as a hybrid.
Yes, if you can.
Thank you very much, sir. Yes, Dr. Satish, are you ready to share the screen? Anand, you sorted
Sir,
out with...
Madam,
Yeah.
Satish sir is disconnected, I guess. Satish
Okay,
sir
so we
is...
go on with our next presentation, Satvir, and then when Dr. Satish is there,
Hello?
we can... Yeah, Anand.
Yeah, Satish sir has come. Satish Mehta.
Okay, so
Now,
we go ahead with the next presentation.
So move on to our next speaker, who is none other than Dr. Govind Raj sir, and sir will be talking about therapeutic colonoscopy. And our esteemed chairperson is Dr. Sanjay Kumar sir from Daltonganj. I would request Dr. Sanjay Kumar sir to please invite Dr. Govind Raj sir.
Thank you, Sadhvi.
Thank you, sir.
Dr. K. Govind Raj is well-known endoscopist, laparoscopic surgeon, and international faculty. I am audible?
Yes, sir. Please continue.
Dr. Govind Raj has a brilliant academic career. He did his MS from KMC, Karnataka, diploma in MIS from Europe Institute of Telesurgery, France, and therapeutic endoscopy from Amsterdam. He is founder of Dr. K. Santha Breast Foundation. He has organized many national and international conferences by his own. He is now Vice President of East Zone IAGES. As present, he is working as Chairman of Dr. Vishwanathan Group of Hospitals, Trichy. Therapeutic colonoscopy is the most important topic he has to deliver. I have great pleasure to introduce and present Dr. Govind Raj for his speech. Thank you. Govind Raj, sir.
Thank you, Dr. Sanjay, for that wonderful introduction. And I will start with my lecture on therapeutic endoscopy. First of all, at the outset, I should thank the ASI Jharkhand, particularly Sunil, my best friend, Dr. Arunima and Satvir. It was, Satya said, it's a wonderful trio which has been doing on this endoscopy and laparoscopy online sessions. I think you have never slept even this COVID, and you have been doing a wonderful job. And this topic will be more of a repetition, because already Dr. Sunil Popat has spoken on the polypectomy, and Ishwar had spoken on the way you do a proper colonoscopy, and Satya has spoken on the pathology. So there will be some repetitions, and I'm going to skip those repetitions. And what are the therapeutic indications for colonoscopy? Basically, the number one is colonoscopic polypectomy. And as you see, previously 20 years before or 30 years before, when we started colonoscopy, the polyps are majorly found only in the Western world. But nowadays, because I would say because of the influence of the Western food habits and constipation, these polyps have become large in number being detected in India, number one. And number two, the colonoscopy is almost available in tier 2 cities or tier 3 cities also. So lot of amount of colonoscopy is being done, and colonoscopic polypectomy is another procedure which has to go to tier 3 cities also. And it should be a therapeutic procedure which is being done by so many colonoscopic surgeons. And next would be an EMR and EST and the colonic tattooing, particularly if you are a laparoscopic surgeon who is doing a lot of colonic procedures. Colonoscopic tattooing is I would say it's a gift, because there have been instances where they have removed a different part of the colon instead of finding that, and then opening up and finding the tumor not present in that specimen. And CALP or LAEP. Just now as Arunima and Satya were talking about the hybrid OTs, this CALP or LAEP is going to be the in thing and the next decade. And reduction of interception is very rarely you see, and that can also be done using a colonoscope. And of course, if you are a center where it's more of oncology oriented, you would see a lot of cancer cervix or cancer endometrium which are being irradiated, and following which you have a side effect of radiation proctitis. And this APC is a wonderful tool where colonoscopy is needed to do a therapeutic procedure. And last, colonoscopic stenting. This evolved 2 decades before, but the indications were not clear. But indications have now become very clear. You can do a colonoscopic stenting prior to a definitive surgery as a stopgap to avoid a colostomy, or it can be done as finally as a palliative procedure. And these are very 2 slides which I am going to talk about the polyp. Sorry for the spelling mistake in the polyp. Polyp prevalence or the size of the polyp is very important, because if it's going to be less than 1 centimeter in size, you don't give much importance to that, as Sunil would have told. And most of the polyps, small in size, are 10 to 15%. The large polyps are 5 to 10%, and very large polyps are less than 1%. That is more than 2 centimeter size. Incomplete resection matters. That is 10 to 30% of the interval cancer is related to incomplete resection. So always you have to study the base of the polyp, and that should be marked separately and sent to the pathologist to study the base and give a definitive opinion. Particularly if you're having a frozen section, do a polypectomy and mark the base and send it for a frozen section to make sure that there is no malignancy in the base. And this is very important when you're doing a lot of EMR or EST also. And what is hot biopsy forceps? Hot biopsy forceps is use an energy source when you're taking a biopsy, and it is very ineffective, and the specimen is difficult to interpret, particularly for a pathologist. And deeper tissue injury, that is thermal injury, happens, and this is the reason the European guidelines have advised to avoid the hot biopsy forceps, particularly for small polypectomies using a forceps. And this one is a cold biopsy forceps. The cold biopsy forceps is nothing but a regular forceps where you use the biopsy forceps for taking a polyp which is less than 1 centimeter in size. That's around 0.5 centimeter in size. You use a polyp, use a forceps and remove the polyp, and you allow it to bleed, but the bleeding stops if the patient doesn't have any other coagulation deformities. What is a cold snare? Cold snare is you don't use any energy source. You can see in this video, on both the videos, what I'm doing here is I'm using a snare, but I'm not using any energy source. This can be done only when the polyp is very small in size. As I said, it should be less than 1 centimeter in size. And here in the left, you saw an image. Suddenly there was a change in the color of the image, where I'm using a blue light imaging, or I'm using a FICE or a BLI, or it can be an NBI. These NBI images, image guided polypectomy, can be done as a cold snare. And here I'm not using, here you can see I'm not using a snare. I'm doing a snare, but I'm not using any thermal or any energy source in that. And what is a hot snare? This is a hot snare here. You can see a large growth here. It's a polyp, which is a benign polyp here, and which is probably an adenoma, which is usually between 5 to 20 centimeter, 5 to 2 centimeter in size. And this, I'm using a complete polypectomy is being done using a hot snare. After the polypectomy is done, I'm using a Rothnet basket to remove the complete polypectomy here. And coming to the EMR. Yeah, EMR. This is another adenomatous polyp which is very flat, which is more like a papilloma in the rectum, where I'm injecting the side of the entire lesion with a normal saline, and I also inject methylene blue into this normal saline to get it completely elevated. Once I elevate it, then I use 2-3 types of knives are there, a hybrid knife or a T knife to cut the entire lesion. Once I cut the entire lesion, I keep on injecting saline to elevate the lesion. Here I have elevated the lesion. You can see nice, you can see the base of the lesion, which is completely getting elevated. And I inject, then cut, inject, and then cut. Once the tumor is cut, you can see the base here. And it takes probably this base, you don't need to use a clip. There are certain areas where you are suspicious there might be a perforation, then you will have to use a clip to completely close the base. These are some take-home points which I should say. Do not use a forceps. Limit a forceps to very small polyps, that is less than 2 to 3 millimeter in size. Use a dedicated cold snare for polyps up to 1 centimeter in size, which is the upper limit. And take a healthy margin, that is gently push, close technique. And you have to have a healthy margin. This is what I said. If you have a frozen section, do the base a frozen section to prove that there is no malignancy in that area. And use a hard snare for larger polyps, which are more than 1 centimeter in size. Examine the margins after resection. If you suspect any perforation, you can do an endoscopic sewing or endoscopic, you can use a clip also. And as I said, this is one rare video which I have here, which is a huge intersusception. Intersusception is from the ileocolic intersusception. And I used a colonoscope to completely reduce the intersusception. And as I progress in the intersusception, it was almost into the transverse colon. And I am progressing, I'm continuously reducing the intersusception, and the bowel get reduced. And as I go towards the hepatic flexure, then I traverse into the ascending colon. At the end of the ascending colon, I was able to see a nice growth in the cecum. That is an ileocecal growth, which is forming the pivot for the intersusception. If I had not reduced this intersusception, I would have missed that growth at all. And what I did was I completely reduced this intersusception using a colonoscope. And after the reduction of the intersusception, I took multiple biopsies to confirm that's malignancy. That's a cecal. You can see the nice growth there. That's a ileocecal malignancy. What I did is I took a biopsy, confirmed it on a frozen section, then took the patient for a laparoscopic right hemicolectomy. Colonoscopic stenting. As I said, colonoscopic stenting can be done as a palliative procedure or as an interim stopgap procedure where the patient doesn't want to have a colostomy. When the patient has a completely subacute obstruction or a dilated bowel where you need to reduce the bowel before you wake up for a definitive surgery, you can do this stopgap interval stenting. Here, that's a stent that's being deployed there. And here in the bottom, there is a fluoroscopic image. You can see as the stent is being deployed. And here, after in the light image, after the stent has been deployed, I'm trying to introduce the colonoscope into the stent. And you can see the proximal part of the normal bowel there in the stent after I introduced the colonoscope there. You can see there. And here, in the bottom portion, there are 2-3 types of stenting can be done. If the patient has already had a colostomy done elsewhere and the patient comes for a palliative procedure, we can do a retrograde stenting through the colostomy site into the portion where it has got completely obstructed, do a stenting, then close a colostomy. We have done few procedures like that. That is called a palliative stenting. And this is the stent which is in the distal portion of the bowel rectum that is there. Radiation proctitis. Here, little bit of theory will be there. Acute radiation proctitis and chronic radiation proctitis. Acute radiation proctitis is a result of radiotherapy, which is involving mainly the outward mucosal layer and usually occurs 3 to 6 months after the start of the radiation therapy. Symptoms are cramps, nausea, tenesmus, diarrhea, and minor bleeding. And mainly the radiation proctitis is a result of inflammatory process of the rectal mucosa, which appears beefy red in color. And there are few treatments which I just wanted to highlight there. These are all the non-invasive treatment that has been suggested. It's all present in the literature. Sucralfate enema has been very useful, which we have used. And other one is the steroid enema. The steroid enema has also been used. These two have been very successful, and we have tried in many cases. which we use adjunct in a case of APC also. That's the reason I put all this theory in this. And the chronic radiation happens very late. We see patients who have had radiation 2 decades before now come with radiation proctitis. Here also, we try the, as I said, the conservative measures. If it is not subsiding, then go for the APC. If the APC is not also happy, if it's not subsiding, the tumor, the redness or the inflammation is not subsiding, then you have to go for a definitive resection. And here there are 2 videos of the APC which I am showing here. The APC probes are either a circumalveolar probe, or it can be called as a side probe. Here in this, what I'm using is a side indirected probe, where I use at least 2-3 sittings I need. And each sitting will last around half an hour to 45 minutes. And you know, APC is done by argon gas. The entire bowel gets distended. So we have to stop in between, suck the air, and then keep doing. And this is a very mild form of a radiation proctitis, where we did 2 sittings to 3 sittings, and we are able to completely settle the bleeding for this patient. And here on the left side, you can see before how it was. On this is the right side, there's a video which is showing is the procedure that's being done. And this is a procedure where you need to do multiple sittings. Organ plasma coagulation. This is what an organ plasma coagulation procedure looks like. And colonoscopic tattooing. Due to early detection of malignancy, sometimes very early, because you use a lot of this NBI, you are able to target the biopsy and take, and sometimes you will not be able to identify when you're doing a laparoscopic resection. And for that, identification for the laparoscopy, during laparoscopy, it becomes difficult, particularly for flat lesions. So preoperative procedure of endoscopic tattooing, or sometimes clipping or barium studies have been used. Tattooing agents usually are methylene blue or India ink. As Satya said, that India ink is one of the wonderful dye that is being used. And nowadays, when you are having a laparoscopy, ICG is also being used for finding out the tumor there. And a spillage happens sometimes, then it becomes very difficult to identify the exact portion. To avoid such complications, there have been few studies which have been suggested, particularly in Korea, using the patient's own blood for tattooing. And this is a tattooing which I'm doing here. And here I use the India ink for tattooing here. First, I always use saline to inject in the submucosal area and increase it to a level. Then I use tattooing there. This India ink, particularly, as Satya said, which even lasts for even 6 months. After that, after a routine procedure, after doing a colectomy, we do a colonoscopy. After 6 months, there was still this India ink there. So India ink is very useful. And now coming to the colonoscopic assisted laparoscopic polypectomy or laparoscopic assisted endoscopic polypectomy. This is the thing which Satya and Dr. Arunima was suggesting. This we deploy in most of your theaters, because most of the theaters, operating theaters, are hybrid theaters. In this, I am going to show a case where it's a video I'm going to show there. We are trying to do a laparoscopic rhytomic colectomy, where a laparoscopic assisted colonoscopic polypectomy. Here, first I do a complete laparoscopic mobilization. Then, as this happens, one of my assistants will start pushing in the colonoscope. And as you push the colonoscope, you can see the polyp there, and you identify the polyp by using the laparoscope and the colonoscope. And then what you do is do a nice polypectomy. And in this case, the advantage of having the laparoscope outside is there. So you can identify there is no perforation. So, but still, I'm putting a clip here. That's a clip. That's a large microinvasive Boston Scientific clip, which has got a wide diameter. And after the clipping is done, you can identify this using the laparoscope also. There is no perforation. And this is one of the procedures where you do a laparoscopic assisted procedure. And this is one of the last slides where I am doing it. Putting this slide is NBIs. After the NBI, we have got a lot of flat lesions which have been turning malignant using this NBI. There are different companies which name this this procedure as NBI is from Olympus, BLI is from Fuji, and iScan is from Pentex. So all these things have increased the advantage of diagnosing these lesions very, very early. So as Satya suggested, so the pathology is now becoming more of an confocal microscopic pathology, which can be identified even in the endoscope itself. With this, I would like to thank again the trio of Dr. Arunima, Dr. Sunil, and Satyajit. Thank you.
Thank you very much, Dr. Govindraj, and it was a wonderful presentation. I would just like to ask one question that you talked about tattooing. So, sir, there is no clear guideline as to when to do the tattooing. So, when do you prefer to do the tattooing?
I always do the tattooing. If I'm doing with an India ink, that should be done at least a day before. If I'm going to do with methylene blue, I would do on table, hybrid.
Thank you very much. There are no questions in the chat box as of now.
No, I just want to share, I have been to Govindra's center. Wonderful, mixture of high-level endoscopic surgery going on there. Good, Govindraj.
Thank you, Sunil.
Miles to go for you. I can see that. Take care.
Thank you.
And I think many of the surgeons from Jharkhand would want to go to your center also.
We'll organize that. We'll streamline from here. It should be.
Right. So finally, we have Dr. Satish Mitha, who has started sharing his screen. So I think we'll have his presentation now. Dr. Midha?
It says Dr. Satish Mitha sharing his screen.
Yes, sir. He's sharing the screen, sir.
That's all it says.
Do you mind if I share his screen? I have the presentation.
Yeah, I think you share his presentation so that he can just speak. And yeah, Dr. Midha, you can speak, please.
No, but something has to.
Sorry, sir is using actually web Zoom.
Sir, are you able to see the screen, sir?
Yeah, it's coming now. So you can help. Satish, you can speak now, possibly. Yeah. It's coming.
Dr. Midha, please unmute yourself and speak.
Kali Satish, थोड़ा short रख लेना. Give us 2-3 minutes before. Satish, can you listen to us?
I think some connectivity problem. Then we can skip to the next one because time is.
I suppose so. I think we have spent a lot of time. Arunima, what do you say?
Arunima is not able to say something. Why don't you say?
No. See the chairperson.
What? Why don't you say?
Chairperson, everybody.
Satvir, have you spoken to Dr. Midha?
Yes, sir. I told sir that I'll be.
I think jump to the next speaker,
fine.
and if there is none, we can conclude because we are already over time.
Patron word is final. Okay, fine. Chal, okay, so let's get into the panel discussion.
Can you see my slides?
Yes, sir.
I'm audible?
Yes,
sir.
Okay. So we are coming to the last part, not the least. I always feel that anyone who is going to have, like ERCP, Dr. Arunima told, what is the complication? It's an adverse event in the event that prevents completion of the planned procedure or results in admission to hospital, prolongs the existing hospital stay, requires subsequent medical consultation or another more invasive procedure, or have surgery, or necessitated repetition of the same procedure, or often needing more sedation. So all these are technically by definition complications. Adverse events can be classified into procedures: pre-procedure, intra-procedure, from entering the preparation area through leaving up to the leaving the endoscopy room,
post-procedure, that is up to 14 days technically, and late anytime after 14 days. And the risk factors in the endoscopy are also divided into procedure-related, complexity of the procedure, patient-related due to comorbidity and the clinical status, and operator-related, that is individual expertise. With this definition, I'm going to the complications of endoscopy. Today, these are our esteemed panel, Dr. Arunima Bharma, the organizer of all these things, Ishar Govindraj, my very, very good friends. We work together as three musketeers, I say. Dr. M. Kanagavel, the best academic person in the whole surgical field in India, I feel. Dr. Shadveer is a very young, enthusiastic person. So with this thing, I'm just, I have to shorten the thing, so very small thing. What are the common complications of endoscopy, we say? This answer is the commonest is the cardiopulmonary emergency. According to the number, in 1 in 500 to 1 in 1,000 cases, we have some cardiopulmonary problem. Perforations happens in 1 in 1,000 to 1 in 10,000. Hemorrhage mainly post-polypectomy, 1 in 200 every cases, and all others are rarely found in the literature. And death happens 1 in 20,000. So nothing is absolutely safe, but all are remote. So get encouraged and go into the next step. Now, first question is to Dr. Kanagavan. What are the patient-related situation you feel which one should be extra cautious about the endoscopy? Dr. Kanagavan, please. Dr. Kanagavel, can you hear? Hello, Dr. Kanagavel.
Kanagavel is not there, Satya.
Okay. Then Ishar, if you...
Yeah. I think as you rightly say, whenever we see a patient, before we take the scope and proceed to perform any procedure, we need to have a good idea about our patient's background, what I call patient checklist, as we mentioned. Because if a patient, for example, if the medical history says he's on some drugs like aspirin, clopidogrel, ideally he should have it stopped at least 5 days before. Otherwise, you are inviting trouble in the way of excessive bleeding. Like that, elderly people or people where you suspect like diverticulosis, there obviously not only the colonoscopy is going to be difficult, there is also a small risk of operation. Any previous surgery, especially pelvic surgery, like a hysterectomy, is going to make a seemingly easy colonoscopy a challenging one. Even crossing a rectosigmoid could be a daunting task. And colitis, if it is acute colitis, because it is not distending properly and papery thin, and because of the bleeding and mucus, you may not see the dark shadows or the lumen very well as you normally do. Whereas on the contrary, I find some chronic ulcerative colitis because of this, what I call a lead pipe colon. Sometimes sigmoid navigation will be like a cakewalk. It will be much easier, paradoxically. Some large hernia, you know, in our country, we used to have this scrotal hernias. I'm sure it will be like you'll be doing a sigmoid, I mean, a colonoscopy, the scope may be still in the scrotum also occasionally. So we need to be careful. You reduce the hernia, then you perform. So you need to see the patient as a whole before you see the patient through the hole. That's what I say.
Fantastic and complete answer. Nothing to actually add. What are the probable cardiac and pulmonary complications that can happen during endoscopy? Dr. Arunima Bharma, to answer.
Yes, so since we are insufflating a lot of air, there can be cardiopulmonary compromise because this patient, like just as we have in laparoscopy, so the diaphragm is pushed up, the cardiopulmonary, the blood return, the venous return is reduced. So even a cardiac arrest rarely has been reported. So most of these are similar to laparoscopy, that the venous return is reduced, there is abdominal distension, the diaphragm is splinted. So all these cardiopulmonary complications can occur in this patient. So we should always keep a pulse oximeter and a ECG tracing whenever we are taking up a patient for any of the endoscopic procedures, especially if these patients have, have any comorbidities. So there is no miss on that, but all this can occur. Rightly said that hypotension, because the venous return is reduced, there is compression of the vena cava. These are the things that can happen. And yes, so you all also have a slide saying that hypotension, arrhythmia, ischemia, and as I said, cardiac arrest.
Yes, absolutely. The pulmonary complication like central hypoventilation aspiration and laryngoscopy. These are the theoretical other possibilities.
Yeah, and yes, so just that aspiration, it is not just that aspiration can happen in upper GI endoscopy, it can also happen in colonoscopy.
Yes, yes, very important point.
Another point, Satya, because here, unlike in endoscopy, we are seeing the back of the patient. Sometimes you are concentrating on the procedure. So vigilance is the watchword, and your assistant is equally important to see whether the patient, a quiet patient doesn't mean the comfortable patient. So you need to be very careful. I think vigilance is the watchword. Monitoring, you should do ideally in any cardiac patient. ECG monitoring is also important, apart from the pulse oximeter. That is a recommendation by the ASG guidelines.
Absolutely. I always, and especially I think many of us use the sedatives routinely in the colonoscopy. The patient is little sedated. So in that case is also the assistant who is standing in front of the patient should know what are the complications and should be trained to notice you, bring to your notice if there is any harbinger of these complications coming. Any steps you can take pre and during endoscopy to reduce the cardiopulmonary complications, Dr. Shadbir, please. Dr. Shadbir, if you can comment.
Before taking any patient to endoscopy, I do like a pre-anesthetic check for an OT patient. I do it for any colonoscopy or endoscopy. So we should see all the drugs he is taking, what is his cardiac status. Patient should have a proper pulse oximeter, and what sir said, ECG monitoring, should have nasal oxygen, and not much of insufflation while doing colonoscopy, and emergency kit ready for resuscitation, and an anesthetist.
Yes, yes, that's very important, because in especially high cases, you start with the anesthesia with intubation. Then the sudden chances of going into problem is much less. So in all the institute we work, we have our anesthetists, but in a few places where you don't have the anesthetist, be careful about choosing your patients. So what are the types and causes of perforation? Govindraj, if you are there, you are a very senior and experienced one, if you give your ideas.
See, in an endoscopy, particularly in a colonoscopy and upper GI, there are different types of perforation can occur when you are an amateur and you're starting, which can be, like as you mentioned, that it can be an early perforation and a late perforation. And particularly, we have seen these kind of perforations when a beginner starts to do a colonoscopy. And basically, the shaft of the scope, the cecal blowout, and the tip of the scope. And the third one, the tip of the scope, is the most common, and particularly in the rectosigmoid junction is where you try to negotiate, give more pressure. That's where the common cause for the perforation happens. And cecal blowout, it all, if you look at the percentage, it will be the least. And the other thing is, if I want to say about the perforations, the late perforation is, as Dr. Ishwar mentioned, particularly in a case of colitis, you have done a scopy, and after the first day, second post colonoscopic day, you can see sometimes the abdomen gets distended, and because the area had been inflamed and that is very papery thin, there would be a perforation, delayed perforation will happen, and you need to identify. Particularly, all perforations, early identification, the patient goes home fine. Early identification, rectification, either you do a laparoscopy or colonoscopy, or if you are advanced kind of a therapeutic eye, do perforation closure using a clips.
I think simple, nicely explained. Only one point I want to stress, my seniors also agree with me, is a luminal colonoscopy. Always you need to have the lumen in the view. And if you don't see the lumen, always prepare to take a one step backwards. See, orient yourselves, minimal insufflation, you go forward. Don't have what we call a leap of faith. Sometimes this is what happening, especially like the risk cases, what we have said, the previously operated pelvic surgeries, that if you persist, then you'll blindly force over sedating the patient, blunting the patient's pain threshold. That means you are inviting trouble. You should be very careful not to do that.
So just I would mention Dr. Kanagavel has joined in.
Welcome, Kanagavel.
Very sorry, sir.
We were
Very sorry.
searching you.
You're very sorry, sir. I had some
already
issues.
told the what are the steps, main steps.
He's the most
Yes,
wanted
I'm listening.
personality across the globe. Kanagavel.
Sir, I'm watching, sir.
Best
I'm watching.
academic person. Kanagavel, I have introduced you the best.
Thank you, sir. Thank you, sir. Thank you so much. Apologies for the delay.
So, except that, what are the steps to reduce the risk of perforation? The most important, Ishwar has pointed out, you should always be in the lumen and don't go blind. What are the other steps? Few we have given, any your comments coming up?
Sir, I would like to say, add to this, I think you have very clearly mentioned the most important troubles. When the patient complains of pain. So that is one other thing which I'd like to add up. And I'm sure when your vision is not fine and say you are spending in the same area for more than 2 to 3 minutes, you are not able to progress in spite of scope getting recruited and your vision is not progressing towards the more proximal part of the movement. So these are the things which I would like to add up to these issues, what you have mentioned, sir. Thank you.
Yes, yes, absolutely.
Satya, I will add one more point to Kanagavel is for the beginners, especially when they do a biopsy, because it's a common procedure, they should realize the left-sided colon is a thicker colon compared to the right-sided colon. Distended colon is a thin colon coming to the undistended colon. And you should take the biopsy forceps and take it gently. You can always have a good control either with yourself or your staff. You should not throw it like a dot. When you throw a biopsy forceps like a dot in a thin bowel, distended bowel, then you have a micro perforation inviting trouble. So you should be very careful what you do. So that should be a good understanding between you and your staff. Open means he should open. Then go and grasp, snap, everything should be under vision, nothing blindly to be done. It's a very common procedure, one of the rare cause for micro perforation.
Absolutely, absolutely. Point usually never mentioned, the fantastic thing. Another thing, Ishwar has always mentioned that while you are doing the colonoscopy, reduce the loops regularly. It's not that at the end you reduce or wait for the patient to have excruciating pain. After each some part you reduce the loop and go, then chances of bad looping and perforation are very less. And other steps, as we have said, that in colonic obstruction, if there is dilated proximal colon, then minimizing suppletion. And electrocautery about the electrocautery setting before and after prolonged application should not do this thing. About the electrocautery, Govinda, you are using so many energy sources. Can you give some tips that about using the energy sources? What are the things we should do to reduce the chances of perforation?
See, if you have a good energy source, particularly the good ones which have got the blended one, the blended current should be the most important thing when you are using a colonoscopic polypectomy. And there, the blended current, always try to go at the lowest possible level of current which you want to do, and then increase it. Usually, in the if you are using a ERP or a Martin or Olympus diathermy, we start around 20 watts. That's a common wattage which we start. We don't go anything above 25. That is the wattage which is most of the time preferred for the colonoscopic polypectomy. And particularly what I meant a blended current is you have a cutting current and a coagulating current. There will be a blending of this cutting and coagulation. If your machine doesn't have this blended current, then what you do is you initially do a little bit of cut and then coagulate, cut and coagulate, but we may not be as smooth as you have a computerized chip which controls the cut and the coagulation. So always use a blended current for using anything in colonoscopy.
So delegates, please have these duels from the seniors because we all suffered and then we have learned.
And Satya, one more point I'll add to Govindraj is to see I always overuse what I call as a sub-mucous saline cushion. Whenever, even if it is a pedunculated polyp, I liberally use the sub because that gives you the cushion, increase the bowel thickness. What is about 2 to 3 millimeter thickness of the bowel, you increase by a liberal infusion of submucosa, then you can be more, because the transmural migration of the electricity is the reason for the, as you know, the post-polypectomy syndrome or a perforation at a later. So you need to avoid that. I think that has to be taught, and it is a very simple procedure. All you need is a 23 gauge long needle, saline. If you have a drop of methylene flow, well and good.
Absolutely. The saline lift, what technically called.
Yeah, if you have seen my video of EMR, I will be injecting saline, then cut, injecting saline and then cut. I elevate and then cut. EMR is always, if you have a hybrid knife, which will do both the things. You can inject and cut in the same knife.
Yes. Dr. Arunima, clinically, how endoscopists will recognize the early or the late colonic perforation clinically and what investigation you should do. Please, a guideline for the delegates.
Sir, if we are talking about early, it is during the procedure that we will recognize. Then
Yes,
there would be early, which will be immediately in the post-procedural period, and there are at times there are late perforations also which present. Like I think in the presentations we have already seen that you have done a polypectomy and that area is very thin and necrosis, and then later on presents as a perforation.
Yes.
So if we talk about intra-procedural, then intra-procedural, when it's a big perforation, at times whenever you are going in and it is not a lumen, we can see structures which are not not familiar with during a it's not a colonoscopic view. It can be some structures like you see in a TEP or something. So that is one thing that, okay, you have gone into the wrong space. That is that will give you an idea that, okay, you have perforated. Then at times patient complains of intense pain during the procedure. That also is the patient will complain of intense pain, and you go into an area where you're not able to guide your colonoscope. That is where you recognize. And then when you have suspicion in the immediate post-operative period, you can do a CT scan would be the best if you can do a CT scan, because that will give you an idea of both the air and the fluid. And if there is just minimal air, at times conservative treatment can work. But if there is fluid in that cavity, in the extra luminal cavity, then you should go in for a surgical treatment. When I talk about late, again, if a patient has undergone a colonoscopy and then has come late in the period with intense pain, and it's similar to any other perforation of the bowel. So you have to go in again with the same things, like you have to take the CT scan. X-rays would not be much helpful in this condition. It would be a CT scan that I would prefer to do. And so, yes, anything else I think somebody can add?
Absolutely. I also feel sometimes about the investigation, you wait for the straight X-ray or for an ultrasound, please go for a CT scan. Otherwise, you may be confused or you may be misdirected. I feel so. And technically, they say the later it is during procedure in the recovery room, less than 24 hours and more than 24 hours. That's the literature divides it. As you have said, all the right thing, very important, because as early as you go for that, then your results are good, which already we have discussed during by the faculty.
One of the horrid sign I have seen, Satya, once is what was a colonoscopy become a laparoscopy. You start seeing the small bowel. That means you are really in trouble, intraperitoneal perforation. That I've seen once right in front of me. Once you see this vision, something like a notes where you see there is a big hole there. Don't be over. I have a good bowel preparation. I can conservatively manage, because at time you are working against the time. Don't hesitate. Unless you are expert in how to manage endoscopically, that is a patient has to go to the theater. That is what we need to bite our ego and go.
Here,
Yes,
I would like to add a point, like what hybrid theater comes into our saving our lives. It is fantastic, particularly for all the people who are trying to start colonoscopy. I would say it is not uncommon to have a perforation. Definitely, it's not uncommon. You can start a colonoscopy, you can have a perforation, but you should identify a perforation, explain to the attenders that something has happened, I'm going to rectify it, get help, do a laparoscopic suturing immediately, because if you have a hybrid theater, you can immediately convert it into a laparoscopy, do a nice laparoscopic suturing, the patient goes home absolutely fine. And if you miss it, and then as Ishwar said, then the problem starts.
Absolutely.
I would like to add one point, sir.
Yes.
Many times, at least in whatever perforations which I have done or I have seen manage the patients, it is a coexisting pathology which makes the situation worse. Especially when you are dealing with the malignancy, when you are dealing with the IBD, where we are doing a colonoscopy for follow-up or a treatment failure assessment. And this is where we get into big trouble, because it becomes very challenging. Are we to repair in a partly obstructed or a partly strictured colon? These are the things one should keep in mind. Otherwise, I'm absolutely fine with my other colleagues who have told about the various aspects. The underlying mucosal status of the colon should dictate the type of the repair one should choose. And here, one should not hesitate to divert if in case of a obstructed colon, or if you cannot plan for a definitive procedure along with when you are handling the perforation. And again, the status of the patient warrants the procedure. As Govindra sir said, it is definitely a right choice. If you have a hybrid OT, take consent, do the immediate repair, and as he says rightly, patient can be sent home. But then patient comorbidities and the sickness also to be taken into consideration. Thank you, sir.
Here, Kanagavel, there are two, you classify into two things: unprepared bowel, prepared bowel. If you say it's an unprepared bowel, as you rightly said, diversion is a choice. Definitely you have to think. Prepared bowel, like Ishwar said, you have a very clean bowel, immediate closure is the ideal choice. So it's two categories you have to.
Point is well taken, sir.
Yes, absolutely. There's the guideline: identify perforation promptly, call for help if you are not adequately experienced, stabilize the patient, hemodynamic support, ventilatory support, analgesia and sedation. And then you go, if acute cases, if defect is small and situation amenable, you can do it colonoscopically. As Sunil was also saying, Govindraj also showing over the tube, the scope. The clips, those are fantastic clips if you have that already available. If occurs outside hospital, arrange emergency transfer and mobilize appropriate team, surgery, emergency department. Don't wait. Inform the patient's family, say what happened and the companion. Don't try to hide anything. Determine with consultants appropriate definitive management of therapy you can do. So one question to Kanagavel, what is the post-polypectomy electrocoagulation syndrome? It's a very technical thing. If you please go on with this thing and the treatment.
This is one of a very rare occurrence, but then one should be aware. Where the typical things what Dr. Arnima was sharing, the typical sign of air under the diaphragm or peritonitis, all those things are not very typically present. Peritonism is the one which is present here. As sir has very clearly mentioned, it is a transmural burn without a leak of air or without immediate discharge of the colonic contents into the abdominal wall. So principally what happens is there is a thermal injury, or otherwise called the thermal burn syndrome. It within 24 hours or up till 72 hours, and the patient complains of abdominal pain, be mindful that something has gone wrong. Yeah, elevation of leukocytosis. See, the common thing all of us do is do an abdominal erect film, check whether there is any leak or anything, which for all reasons may not pick up anything, but still the patient can complain of pain. This is the one of the unique situation where imaging has to be very judiciously assessed. But be mindful, colleagues, if the patient tells about pain after you have done a polypectomy, even without signs of air under the diaphragm or free air or free contamination, this is one typical unusual phenomenon you should keep in mind, which still be able to manage with bowel rest, but at times it leads on to the bowel perforation also. So this is very important for you to avoid probably unnecessary exploratory laparotomy. I would say what Govindra sir said, maybe a inspectional laparoscopy may be a better choice to have a look on it. But then the person who did the colonoscopy is the most ideal person to do a laparoscopy, because he knows where exactly and what exactly he has done. He knows which wall of the colon is the problem. Many times, if it is the retroperitoneal wall, then it becomes a challenge. Are we to mobilize? Are we not to mobilize? These are all the special consideration. I'm sure the more senior colonoscopists you become, you get to learn all to this. Thank you, sir. I would like to listen from the experiences of the other panelists and Satyapriya sir as well.
Absolutely. Only one question. Govindraj, will you go for a check laparoscopy in this type of cases, or if CT says no, we'll wait?
Check laparoscopy.
Yes, yes. I also agree. I feel that's the best place. Sadhvi, what are the causes and how you manage the hemorrhage during endoscopy? Because you are coming up. So these are the things you have to now face and you have to do in your place.
Yes, sir. So first of all, it's about early hemorrhage or the late hemorrhage. If it's at the site of whatever I'm doing, I'm seeing a hemorrhage and the patient's coagulative profile is normal, the hemorrhage will stop immediately. But if it's bleeding, then I will use use of injection adrenaline or a balloon tamponade to stop that. And for late hemorrhages, I'll do a thorough coagulative profile and then see where exactly what is the bleeder point, get a CT scan of it.
Arunima, only one comment on the balloon tamponade. I have never thought of balloon tamponade in case of bleeding.
No, sir. Colon's balloon tamponade, I don't think I have no experience also of this. Balloon tamponade would work more in more rigid structures like esophagus, where at times we are dealing with varices. Not exactly fit for colonoscopy. Recently, I have been hearing a bit about stents which are being used to control bleeding. I think somebody who has experience like Dr. Iswar Murthy or Dr. Govind Raj can comment on this. Balloon tamponade.
Colonic bleeding stents are not being used. For particularly upper GI bleeding, I have got experience in using stents. It is very useful. Sometimes you don't know where it is bleeding from. Put in a stent, just buy some time, wait, and the stent can be removed later also. You will have time, 3-4 days, no bleeding, the patient becomes better. Then there will be a reactionary hemorrhage when you pull down the stent. That is bound to happen, but you will buy some time. But colonic, there is no evidence of having.
Even in ERCP, sir, for that we are using stents, but not. I think in this you have to go ahead with placing clips. This is what you have to do. You are able to find the point, or go ahead with surgery and resect the segment.
In ERCP, in ampullary bleeding, we do use balloons. Use a balloon as a tamponade.
But I was seeing a SAGES program in which they did mention about stenting it for bleeding, and then again, as you mentioned, you have to take that out.
They use balloon. If that doesn't stop, they do a stent.
Yeah, that's obviously a stepwise system. Stent would be the last resort.
I think to add another point from what I can hear from Govindraj Arunima is to have what we call a trouble prevention than a trouble management. That is, when you see a large polyp or a thick stalk, or when you have a patient where you have a chance, like elderly people, where you have chance of propensity of bleeding, you preventively, you have to give either a submucosal saline cushion, mucosal lift with the adrenaline. You have the electrocardiography setting in such a way that you need to have, like, for example, nowadays, like machines like, ERCP, they have, you can manipulate the time interval and the cut duration, all those things. So we say the endocut Q is what we normally use for all this procedure. But even there, you can micromanage these settings in such a way you get a good hemostasis. And there are like Olympus endo loops available. You apply the loop before you start snaring or chopping the polyp. So there are ways to manage rather than seeing it bleeding right in front of your very eye. But if it bleeds, immediately you take the injection needle, inject, minimize the bleeding, then clip may come for a rescue. Don't clip blindly, because otherwise you'll be wasting more than one clip, 2, 3, 4 clips. Then you can't use a diathermy there, or you can use energy sources near the clip is contraindicated. That's another point I wanted to drive the message across to the people.
Very important. Kanagavel, one question to you, as you are maximally exposed to literature about this use of antiplatelet, anticoagulant. There are now few confusions. Previously, they used to say you don't take biopsy if you are on antiplatelet, and now they are saying only weak polyps also. So what's the latest situation? Literature says about stopping this antiplatelet and anticoagulation or NSAID for this therapeutic colonoscopy.
Thank you, sir. That's the most pertinent question, as we are getting aged population and more multimorbid complications whenever we are planning for endoscopy. Sir, I will stratify this into two important types. As Govindra sir says, planned and unplanned colonoscopies. If it is a planned colonoscopy, it is preferable you stop the drugs depending on what type of blood thinners you use before for a regular colonoscopy. Now, the most recent update says for diagnostic colonoscopies and biopsies, you need not stop aspirin. But if you are using clopidogrel or one of the NOACs mean the newer oral anticoagulants, it is preferable to stop. If you are using warfarin derivatives or aminoglycan derivatives, you have to essentially titrate the PT-INR. You have to either stop the drug and reach the desired PT-INR, or use a corrective agent and reach the optimal PT-INR if you are planning for an intervention on your colonoscopy in one sitting. To simplify, very simply, diagnostic colonoscopy, preferable to stop clopidogrel if you are doing on an elective basis. Not necessary to stop aspirin if you are doing for a diagnostic colonoscopy and planning for a biopsy alone. Step number 2, interventions. Categorization of the interventions. If you are seeing a possible potential to do a polypectomy, if the patient is on blood thinners, if the patient does not have complications, it is desirable to wait, relieve the intensity of the anticoagulant status, and then do a planned procedure.
Is that correct?
Number 2, if you are using, especially when you are using valves, bioprosthetic valves, where you have to maintain a high PT-INR, then it is preferable you change the anticoagulant to a low molecular weight heparin over the past 3-4 days. Withdraw 24 hours prior to the procedure the low molecular weight heparin also, and please restart the low molecular weight heparin within 6 hours of your intervention. This is a broad classification, sir, but I would say an individualized primary status have also to be assessed. See, being on blood thinners or being on functional coagulation failure like cirrhosis liver, or patient is having some other decompensated states are totally different, has to be taken with a pinch of salt when you are planning for an anticoagulation correction. Thank you, sir.
Fantastic.
I just want to add just one small point. Even from the very beginning of your treatment algorithm, involve the cardiologist who originally prescribed, because he exactly knows how important the drug has to be continued. Always keep medical legally, I think it is required. We need to always in constant touch with them when to stop, especially patients on warfarin, because patients on mechanical valve, they are very, very particular INR, what INR they have to be and all those things. I had a tough time, couple of patients. That's why I'm coming to. Thank you.
Absolutely. I totally agree with him. I feel that few of the cases, even stopping can cause their life. So we should make a good coordination with them and go further. One question only. In my place, Kolkata, we have very good interventional radiologists who can stop the bleeding. Any of the faculties, do you have any experience that after this, before going for the extreme surgical resection, have you tried for the interventional radiology after colonic bleeding? Anyone? Arunima, in your place, interventional radiology or Govindraj or Ishwarmurthy or Kanagwal?
Sir, we have interventional radiology, but what you are talking about is vascular intervention. No, sir,
Yes.
we do not have any.
Okay.
We do not have any at the moment here, and I think most of them we do send to Calcutta.
Okay, now Calcutta, now they are doing extremely very good.
We send it to Calcutta because here we are having, at my center itself, we have got a very good interventional radiologist, but he has still not done any vascular intervention till date.
Not for colonoscopy-induced bleeding, but bleeding source which was not identified or controlled by colonoscopy. The interventional radiologist is able to identify one or two cases of AV malformation. They are able to embolize therapeutically. They were able to do that and able to stop the bleeding in a right-sided colonic lesion long time ago. So they have a role to play. We should not forget both in the diagnosis and the therapy at some stages.
Govindraj, your last comment, and we'll go for the rare complication last.
Yeah, like as Ishwar said, the intervention radiology of vascular nature is yet to come in our center. We don't have a vascular thing. We have had this kind of the nuclear medicine also used to help us previously for unknown bleeding. And now the intervention radiology is used because they identify the bleeding, but it should be more than 5 ml in 1 hour. That is the only thing. If in a nuclear medicine, if it's less than 1 ml per 1 hour also you're able to identify, but only thing we will not be able to pinpoint. Here we are able to do that, and of course coagulate the area, put a coil in that vessel. A lot of therapies can be done if you have an intervention vascular radiologist.
Sure. So these are the other very rare things which are also mentioned. Remember, even IV site infection and infiltration that's been mentioned during colonoscopy as a complication. Rarely renal injury happened after colonoscopy, and splenic hemorrhage is even not that rare like renal injury. Splenic hemorrhage or splenic rupture even happened, especially in cases of used splenomegaly. Electrolyte imbalance can happen, especially in the older patients. Even post-procedure fall, medico-legally are taken as a complication of colonoscopy. So even in the restroom, there should be sisters or the nursing staff who are very careful about that. And that's why they've given the steps to prevent fall also in American called guidelines that put aside the rail immediately after colonoscopy is over. Make sure patient recovers fully and with escort while leaving endoscopy center. Utilize safety belt in each case. An assistant trained to prevent the sedation-related fall during the procedure and recovery period. As the Ishar Murthy was saying, the whole team actually matters. So at the end, any other complication rare, if any of the faculties have faced, please give our experience.
I have two things to add to your big list. One, of course, is one of the commonest thing is missed lesion. Because if you miss a lesion, like if you think that you have already gone to seek up, but you've only seen hepatic flexure, you miss a lesion, and one other colonoscopy is finding a lesion, that a court sees as a complication. So we should be aware of that. So whenever you are not able to explain the patient's symptom like anemia, prepare to do an investigation like a CT or even colonic capsule, things like that. So you should know the limitation. The second thing, curious, I have seen in the literature yet to see is a explosion, gas explosion. I think people say when I'm using things like lactulose or mannitol, those days we used to have because of the methane and hydrogen. That's why people drive, whenever use diathermy, always use carbon dioxide. Now we are much more comfortable whenever you do a carbon dioxide insufflation, we are doing a diathermy. That is a very important standard of care in 2021. I think Govindaraj will agree. Without that, I think we should not use diathermy in a luminal endoscopy.
Absolutely. Governor, give your opinion. Last 1 year, of course, the management to have the CO2 application, that's also a costly affair with Olympus, around 4 or 5 lakhs, but definitely that should be done during all therapeutic cases. Govindra, your
yeah, if you are going to do a therapeutic colonoscopy, I would say first you should have an anesthetist by the side when you start doing therapeutic. You don't venture to do with your own IV sedation because you have another pair of hands to help you out when you have some complication. And number two, like Ishwar said, nowadays we have a routine of carbon dioxide insufflation, which is very compliant with the patient. Post colonoscopy, it is very, very easy for the patient. The distension is very easily absorbed. And number three, very important point I want to say, in my practice, I have seen at least 6 or 7 cases of sigmoidoscopy being done for hemorrhoidectomy. And finally, the patient has come up with a growth in the proximal part of the colon. So probably I feel still a colonoscopy, if available, could be done for most of the hemorrhoidectomy that's being done. I don't know what are the other seniors seen. I've seen 6 cases, hemorrhoidectomy being done, and then the patient continues to have a bleeding, for which the surgeon who operated had done a sigmoid, a very short sigmoid, and the patient had a growth in the descending colon or the splenic flexure, which was obvious reason for the bleeding. So I would suggest probably most of the cases, if possible, get a colonoscopy done before doing it.
Okay,
Yes,
excellent point, Kunraj. I will also keep in my mind.
Yes.
Many of the time I did sigmoidoscopy only for the sigmoid before the hemorrhoidectomy. So as a whole, we have to, every good thing has to come to an end.
Kanagavel wanted to say something.
Yeah.
I'm sorry if I'm taking only 1 minute of your time.
Yes,
the point I'd like to add is
please
have appropriate and adequate anesthesia or sedation whenever you're doing a colonoscopy. At least in 2 situations, patient who came out of the anesthesia during the colonoscopy or during an intervention has created me trouble. So keep the plane, request your anesthesiologist to hold at the right plane, because what happens is it is a totally unintentional thing. The patient bucks immediately, especially when they have an LMA or when they have a non-conventional, non-intubated anesthesia. Jerks and you lose the control. Patient starts moving. That is where you lose control in colonoscopy. This is one other caution I'd like to tell my younger colleagues, so that if you are planning a procedure, request your anesthesiologist to maintain the plane till you pull out the last bit of tube out of the colon. This is one other additional point I'd like to add up to my younger colleagues based on my own personal experience. Thank you, sir.
Thank you. Thank you, everyone. As a whole, the colonoscopy is a safe procedure. That's the take-home message. All complications are uncommon. Every colonoscopy should be aware of all potential complications and to reduce the morbidity. and prevent mortality in all recommended precautions should be followed. I would have a dream thing if I could have had this type of complication discussion before I started my endoscopies, but unfortunately there was none. Great respect to all the faculties, because every time I moderate, I learn a lot from these people. They are a fantastic lot. So thanks everyone. And now we are going for the conclusion.
Thank you, Satya. That was wonderfully orchestrated,
you, Satya.
nicely done moderation. Well done.
I think we'll have the last presentation by Dr. Satish, because finally we have his presentation. So Satvir, but we'll have to make it a bit short because we have already overshot the time.
Yeah, sure. I'll try to be short. Regarding the drugs in the endoscopy, we use analgesics, antispasmodics, sedatives, antibiotics, various types of dyes, anesthesia drugs, resuscitations, and oxygen, etc. Next. We know that we have already discussion on this, that sedation is very important. We mostly use in anxious patient, children, request by a patient to improve the tolerance and for the smooth examination. But for the practical purposes, we need to have sedation in colonoscopy as well as ERCP like procedures. Upper GI endoscopy in our country, we mostly do under spray local anesthesia, but there are patients who are very anxious and children will need the sedation. And the drugs usually used are midazolam and diazepam. And we have to use some surveillance, and oxygen should be ready, and antagonist should be available. If you are using midazolam, it is flumazenil for the midazolam. Don't have anyone for the diazepam. Midazolam is a very short acting benzodiazepine, which is a sedative, anxiolytic, and causes amnesia. It is a very short onset of 2 to 3 minutes, and dose is usually 1.5 milligrams slow IV, and children is lower dose. And we may have side effects like hypotension, respiratory depression, apnea, paradoxical reaction, local pain, and induration. And as already said, antidote must be available. Diazepam is a short acting one, is a sedative anxiolytic, but is lesser used nowadays and it has no antidote, and side effects are same as midazolam. Next. Analgesics, we use various types like pethidine, tramadol, fentanyl, NSAIDs, ketamine, and only when we are assuming that there is going to be some pain or we are going to have some dilatation, etc. And it is contraindicated in emergency in non-intubated patients when there is a respiratory and circulatory failure, but they may cause bradycardia, respiratory or circulatory depression. So they have to be used with caution. Antispasmodic, the commonly used drug is butyl scopolamine, and it eliminates the possible interference from the peristalsis, and it is indicated in pyloric spasm during colonoscopy if you are having difficulty in progression, and also in ERCP. And we have to be very cautious in using the patients with glaucoma, prostate hypertrophy, and arrhythmias. They can cause dry mouth and tachycardia. Next. Antibiotics are usually not required during routine procedures, but if we are doing some therapy like sclerotherapy, polypectomy, stenting, dilatation, we may require, and especially high-risk cases like cardiac valves, artificial valves, indwelling catheters, or having hematological diseases, or on immunosuppressants, HIV patients, or compromised liver and renal disease patients may require antibiotics. Next. Some children usually they won't cooperate, so these are the patients who will require the sedation. Next. Our aim is to guard the patient's safety and welfare, minimize physical discomfort and pain, control the anxiety, minimal psychological trauma, and maximize the potential of amnesia, control movement to allow safe completion of the whole procedure, and return the patient to a state in which safe discharge from the medical supervision is possible. And we need a good team. A trained anesthesiologist should provide the anesthesia in remote locations within the hospital. However, non-anesthetists are allowed to provide conscious sedations. It is mandatory that all providers should be certified with adult cardiac life support training. Sometimes there is a limited working space, limited access to the patients. There may be electrical interference because of the phones, lightning, etc. Old equipments are there, staffs are less familiar, and there are less skilled personnel, drugs and supplies, and there are often no regular check-up of the anesthesia inventory. Next. And then the patients start desaturating, and one may ask for something which may not be available. Next. There are various challenges. First is the challenges of the equipments, and we must be aware that what type of machine is available. We must do the routine safety checks. Many of the times these machines are not being regularly used, so they must be lying in one of the corners. So we have to be very cautious about this. Next. So equipments which must be checked usually are suction, oxygen, airway, face mask, ETT, pharmacy, all the emergency drugs, pulse oximeters, defibrillators, all these must be available and must be periodically checked. And emergency trolley must have defibrillators, oxygen source, cylinder keys, illumination of the laryngoscopes, and backup of at least one full oxygen cylinder if there is no pipeline existing. Next. And all the monitoring devices are essential nowadays. Besides NIBP and ECG, ET CO2, if we are using CO2 in the colonoscopy and ERCP or doing more advanced work, and the expired CO2 is censored along with the graphic display of the respiration. Many a times we may need peripheral nerve stimulators. Next. Staff is again a great challenge, and we must train our staff regularly and ensure rapid communication between the colleagues, and we must identify the assistant to help in the need. Next. And check the consent, etc. before starting any procedure. Before starting any procedure, we must think and plan the moment you start the procedure, anticipate the problems which are going to occur, and help from each other whenever required. Next. And whenever there may be challenges with the anesthesia techniques, monitoring, sedation, regional anesthesia, or TIV, TIVA, or general anesthesia, depending on the as per the requirement. Next. TIVA is usually less invasive, cost and time saving, and there are various drugs which are being used. Usually we use the propofol. Next. And we have to maintain a balance between the conscious sedation and the deep sedation, and patient can easily drift from a state of conscious sedation to a deep sedation depending on the age, sensitivity to the drugs, and the health station. And the dosage has to be titrated and the patient has to be monitored. Next. There are various risks which can occur with various procedures. For the TIVA, I have already told about the drugs used in the TREVA, and airway is usually maintained. Sometimes LMA may also be helpful. Next. The benefits of TIVA, it is, but there are certain disadvantages also. And usually nowadays, due to medical legal reasons also, we need to have our anesthetist at our hand. Next. These are the drugs which are we using for the TIVA: midazolam, fentanyl, propofol, ketamine. Ketofol is not available in our country. Propofol is the usually used drug with load. We load with a 2 milligram per kg over 10 minutes in a 50 ml syringe pump, and in children less dose is required, and we can set the maintenance dose as usually half, and it can be administered either intermittently or by a syringe pump. Dexmedetomide is also used as a sedative in the presence of anesthetist, and it again has a, but we have to see what type of patient we are using, what is the indications, and what is the cardiac and other conditions of the patient. Accordingly, we can decide our strategy. Next. There are various challenges with the procedure, and we have to be aware of the situations, and we have to access the airway also. Next. And the patient position may also change during the procedure, so we have to keep that in mind, and in case of emergency we have to change the position so that we can resuscitate the patient when required. Next. And duration of the procedure is also not predictable, and some of the drugs may also act abruptly also, so we have to be careful with that also. Next. We have to be post procedure also, we have to take care so that patient returns safely to the recovery room. There is oxygen during the transport, and patient who required elective post-operative ventilation must be transferred with the continuous monitoring. And some patients may have anaphylaxis, so we should have drugs for anaphylaxis at our disposal. Sometimes there may be radiation exposure, so we must keep that also in mind. And intermittently we should check our syringe pump and three-way. All these are turned in the proper direction, and breathing pattern is normal. That must be kept in mind. Next. So this is again a similar thing, and we should keep all these things in mind. And whenever we are discharging the patients, we must see that patient is in fit conditions and all the parameters are working normal. Hydration, blood pressure, all these are maintained, and the patient is able to talk and follow your. And the proper records must be maintained regarding the timing, dosage, etc. All this should be properly maintained, which is very important for medical legal reasons also. Next. So this is the just a flow chart that how the patient comes and how the procedure is taken and then goes back to the recovery room. Next. So To conclude, we must be familiar with the territories in the there, and differentiated reflexes should be of the room staff, and emergency situations must be sometimes we must also do the drills, and insecurity due to very realistic anticipation or lack of equipment or staff support must be kept in mind. Next. And emergency drugs like atropine, adrenaline, all this must be at our disposal, and we must regularly check that they are properly kept, they are not expiring, and are available in the adequate quantity. Next. And all these equipments, laryngoscope, airways, masks, defibrillators, and oxygens, and must be there. And this has to be done in a teamwork also, like any other procedures. Only the operating surgeon is not responsible. Each and every member of the staff or technical personnel, they are equally accountable, and they are supportive to us. So next. Thank you very much, and sorry for the technical hitch we had.
Thank you very much, Dr. Satish, for that wonderful presentation. That completes the scientific deliberation, and I think we will, without the presence of all these esteemed faculty, it would not have been possible. And we have tried to give the best that we could. But I would like to hear from the faculty who have joined in. So we can start with Dr. Iswar Murthy.
Adima, what I can say, I think it is really a collective effort from your team. I think you conceptualized with the right topics, and you got the speakers who, back deep in the heart, they feel that they have to share the knowledge to the surgeons. Always is a great feeling. Surgeons, speaking to the surgeons in the art and science of endoscopy, I really enjoy the platform, and you have given me not once but twice, and third time lucky we'll have one more program with the more collectively. And again, I think it is going to be, I hope this becomes an interactive one, like other chapters, ASA chapters also do take. And having had Abhay Dalvi and also Siddesh, I'm sure they've seen the initiative and interest. I'm sure that national level, they are going to take it, and IAG is already doing it. You are doing a commendable job, your academic thing, and you, Satvir Singh, and with, I think, ever-present enthusiasm, I really admire here. So good luck, and from the bottom of the heart, as a faculty, we really enjoyed the day, and thank you, Sunil, thank you all. Great day.
Thank you so much, Dr. Iswar Murthy. I'm sure we would do more with all of your support. It is only your support that we are able to make such wonderful programs. And Dr. Kanagavel has been a constant support. I think any time I have asked him for any kind of academic deliberation activity, he has always encouraged so much. Sir, a few words from you, sir.
I'm sure under the new leadership, I think I've been associated with Jharkhand ASI for the last 1 year or so. Of course, Sunil sir and madam has been known to me for a much longer time. Jharkhand, I think you are taking a unique path amongst all the state chapters where your creation of academic program is not orthodox. I'm sure you think about novel ideas which are applicable to today's scenario. Many chapters are sticking on to the orthodox things, and they end up having the academics to suffer. And I'm sure Jharkhand has taken the right path of bringing in what is essential for the practice of a modern surgical fraternity. So I'm sure more programs, and on behalf of Chennai and Tamil Nadu, I also look forward to have a combined program very soon with Jharkhand, which has been quite some time due to various reasons, I understand. So we look forward to have more combined programs. And I congratulate every speaker. Every speaker has done the justice. But I think this is much more, it warrants more time rather than squeezing into this 2-3 hours, so that the speakers also have some more freedom and the topics also can be given more extended freedom. I think overall, a brilliant show. Thank you, ASI Jharkhand, for the invitation. I also thank the other leaders, Ishwar sir, Sunil sir, Abhay Dalvi sir, Siddesh sir, and the entire gamut of the faculty who made this evening a best possible day. Thank you, one and all. Goodbye.
Thank you so much, Dr. Kanagavel. I'm sure we would do many more programs together. And I think at some stage, Sunil sir, myself, we would want all of you to be physically present here to have your proper space. Thank you very much. I think we have Dr. Chauhan from TMH Jamshedpur. He has always been a part of all the programs that we do, and he comes up front and is always very supportive. Sir, would you want to say a few words?
Ma'am, I take this opportunity to thank the energetic team under the dynamic leadership of Dr. Sunil, who has taken the great pains to popularize endoscopy, including therapeutic endoscopy in this part of the country. And the way he's organized the great subject experts who shared their tips and tricks and the pearl of wisdom will go a long way in popularizing this colonoscopies and endoscopies and advanced therapeutic procedures. Thank you very much for involving me in these programs and updating us. Thank you very much, ma'am.
Thank you very much, sir. Anyone else who is present wants to say anything before we end this program?
When is the next program?
Next month.
Good luck. Good luck.
Thank you very much. Sunil sir, would you like to say a few words? And I think Dr. RP sir would be joining in, so he can also say a few words.
Is he there? RP is there? Or has he gone?
I think he will join in.
RP, you are around? Or has he gone for lunch? We got little delayed. No, that's little, I think we should finish by 2, but anyhow, it was so interesting. But I must thank everybody. No, it's okay. I have my little bit of umbrella, but it's basically Arunima is doing the main job, and then she's taking the surgical activity, endoscopic activity of this region. So thanks, Arunima, for your dynamic presence and dynamic leadership. And thank you everybody. I mean, all of you are my friends, and Chauhan is the new intern in Jamshedpur, and I keep involving him because he's also the academic or DNB coordinator, and obviously the training will get imparted. But Ishwar, Kanaval, and all the galaxy who have joined, they're all friends. We keep meeting. Unfortunately, because of COVID, we are not meeting physically, but at least online. But thank you very much for gracing the occasion. It makes us feel very happy and very important, because see, people think that all the big shot of the country has joined. Ishwar, your books has come. Kanavel, I can see you in the Facebook and we're driving the academic activity. It's huge. So it takes takes a lot of pains. It's not easy to do that. You got to burn the midnight oil. But anyhow, privileged, honored, and will continue to do so under the dynamic leadership of Dr. Arunima.
The next confirmed on-site training program from the IAGS platform, Sunil, you might know, is going to be in Chennai. On behalf of IAGS in Chennai, I'm sure Kanagavel will look forward to meet you all in the EFAGS happening in Ramachandra in September 24th onwards. I think on behalf of Kanagavel, Professor Balaji Singh, I extend the invitation to all the people, faculties, please spread this to Jharkhand, and let us start, because better days are ahead. I think we need to start moving forward, and we'll do it. If not completely on-site, it will be something like a hybrid program, because we want to have a hands-on training, and that's where we are going to have a wonderful platform to train our youngsters.
Kanagavel did invite me and Arunima for physical some conference, but we'll do it. I was in MG Ramchandran a few years ago as a DNB examiner, so looking forward for that. But it's okay, we'll catch up.
Thank you.
Yes, sir. Looking forward to catching up with all of you in person. And we have got our patron, Dr. RP Srivastava. So, sir, RP Srivastava, sir, some final words from you as we end this program.
Dear friends, it is really honor to the Jharkhand chapter that friends from all over joined on a wide coverage, and you all are, it's our dream which is going to be realized through all these efforts, and people have sustainably supported our endeavor. Jharkhand chapter is indebted in particular to all the faculty and in general to the whole governing council and the office bearers of ASI. Sunil and Arunima, they are leaving no stone unturned for making the academic activities going great. Satish from Ranchi, far and wide, Sadhbir as the young volunteer. They are doing exemplary job. Our secretary Sanjay from Dalton, maybe a remote location. He is doing fantastic coordination and leading the chapter from the front. I personally thank you all on behalf of the Jharkhand chapter as well, and look forward for such meetings in future. Thank you very much.
Thank you very much. So with this, we come to the end of this meeting. And we do look forward to more such meetings and meeting all these esteemed faculty. Thank you very much. We would stop the online streaming now, Anand. And
thank you very much.
Yes,
Great job.